considering the position you're in. So today, for those of you who are new, we're going to follow the standard format, which is in the morning, you're essentially going to look under the hood. The vendors will come in, they're going to come up one at a time, and frankly, not kill you with details. The idea is not to have your eyes rolling around, your head slamming down because there's so much facts. They're going to do instead, we've asked them to be brief, 10 to 15 minutes max, but to focus on the overall picture of what's happening in the medical claims, the dental claims, the vision claims, that type of thing. But then what are the takeaway messages? What are the things that pop out at them? So instead of giving you numbers, we're going to try and give you insight today. So we'll do that all through the morning. And then later on, what we'll do is have Chris, the actuary, we'll walk through some numbers, okay, so we're going to do that. Here, to set expectations, where this year is going to be different is I do not believe you will actually complete the process today. Okay, we have a number of moving parts. We got 2 e-sessions that we're going to do today for contract negotiations, both of which will impact both the final costs and the final benefit offerings to counties. The two underlying themes you're going to hear today from us, from Gallagher, is we're going to talk about how setting the rates for the year, you must look at the delta in the funding. Okay, we know we lost about $900,000 in the year ending June 22. Frankly, it's up and down. We were at a loss, now it seems like we turned for the good. So we need to get a little better predictability there. But that gap is now between 17 and 18%. We're about 17 or 18% short of the actuary's rate. That is not a bad thing. It was done by design with county staff, with the board, because we were banking too much money in the surplus, and it was like, that's absurd. We're taking money that could be provided or used for county services. However, we are back into an inflationary environment on things like CPI, we're all seeing it, and medical always runs 2 to 3 times CPI. So right now it's manageable, but the concern with that delta is it will get away from you. It's undoubted, it will happen. So when we're doing our presentation today, we recognize you will ultimately make the decision, but when we're doing our presentation, we're going to be saying, guys, we got to close this gap. We got to get a grip on this because right now we're okay, but we're gonna achieve the goal of getting rid of the excess surplus. We don't want to get below that number. So let's talk about that. And then secondly, the other theme will come from Ken and his staff, which is that they know where the benefit offerings are weak relative to their competitors. And part of the reason that we're going to say at the end, we'll go through all the kind of the things we're thinking and how we're looking at accomplishing things, but very specifically, they know, and it's a fairly easy area, it's in the vision, and to a lesser degree in the dental as far as subsidies, but they know that their competitors, City of Kingman, Mohave Community College, other cities, have a stronger benefit that way. So part of the reason we're going to hit the pause button and go back with the actuary, go back with staff, is how do we, recognizing we got to deal with that delta, how do we fund making the benefit package more competitive so you can compete more effectively in your local market? So it's kind of complex. In the end, what I would think is we'll be back to you asking for a meeting in 2 weeks, maybe 2.5 weeks. It's very hard to get a quorum with you guys. So what we're going to attempt to do, we'll huddle with staff, we'll huddle with the actuary in those days following this, but we're going to try and get a meeting on the calendar very quickly. So we got you locked in and then come back with the final recommendations in 2 weeks or so, 2.5 weeks. Okay, so I wanted to make sure I set that expectation so at the end you don't look at me and go, Aaron, how do we wind up? Where are we going? I don't expect that. The nice part is when the vendors are coming up and we're proposing things, there's a proposal on the wellness side that came from the wellness committee. You've got time to actually contemplate it, look at it, ask questions of the vendors, and we're still going to get you out here early. Okay? So Madam Chair, with your permission, I'm going to turn it over to Mike Cody from Meritain, and he will start that under the hood part where the vendors come up and start walking through that.
Thank you very much, Aaron.
All right, good morning, everyone. Thank you for allowing me to be here and to present to your group the 2022 claims data. I'm Mike Cody from Meritain Health. I am the account director for Mohave County. First time meeting all of you, so it's been a pleasure, thank you. And I inherited this account from Leslie Hagan, who is now happily retired. I hope that I can, fill her shoes and work well for the county here. Just a quick note on, let's see here, there we go. On Meritain's principles and philosophies. we believe in simplicity, transparency, versatility, and I'm a big believer in those principles, and we try to put those principles in place in all of our client management. The payment integrity of this plan, overall savings with Meritain this year for 2022 was $425,150. And you can see under the active services, those are all of the services that we provided and that accumulated towards that savings. Our network access savings was $5.6 million, and so even though we were not the primary network, the wrap network has been working well this year. I think it was due to a higher claim volume. That's why that savings looks so high. Last year, there was only 1.5 million, so I just don't think the utilization of the wrap network was quite as high last year in 2021. So you had, I'll run through this pretty quickly, 2,156 members, not much change in the enrollment in the members in 2022. 80% of your population is in the EPO plan, 17% in the HDHP plan, and we also looked at how many people in the HDHP this year in 2022 came from the prior EPO plan, and it was 3%. Your claims per member per month, $487, and that's a 20% increase from the previous year. I believe, and Aaron can verify this as well, that most of that comes from large claimants. It still is 6% below the Meritain book of business. When you add up all the copays, out-of-pocket costs, deductibles, the employees on average are sharing about 14.6% of the plan. Your high-cost claimants, 5.48 million, and those are for claimants over $50,000, and that represents 44.3% of your total claim spend. The medical trends, you can see that the plan paid 22.4% higher than the previous year. That's the blue bar going up. The two blue bars going down. Emergency room visits are down 21.8%. That's a great trend. Not so good a trend is preventative services. The utilization of preventative services is down 18%. I'm sure Missy will address that a little bit more. This slide's kind of busy, but I'll try to get through it quickly. You can see the red arrows there. Those are increases. The green is decreases. So the musculoskeletal system claims were up 130%, 46% higher than our book of business. Injury and poisoning claims are up 150%, and that's pretty much how much it's above our book of business at Meritain. And some of the definitions here of these diagnostic categories are a little mystifying. This one here, the injury and poisoning, is a broad category. Some examples that might fall into that category are like adverse medication interactions, misuse of opioids possibly, and maybe adverse reaction to, say, anesthesia. So very broad, and if you want us to drill down on any of these, we can. Circulatory system claims, those are generally heart attacks, those are up 59%. And then signs, symptoms, and ill-defined conditions, which is another nebulous diagnostic category, that's up 17%. And that would be like maybe 2 or more diseases is kind of ill-defined, right? Maybe an alteration in consciousness, something that happened where, they have fainting spells or whatever, or even sleep apnea is an ill-defined. So those are examples of those. When we look at the claim distribution, nice trend here that 90% of your claims are $0 to $10,000. You really want to see that every year. As far as inpatient, outpatient, ER, professional, I just look at that top line there. Number of claimants in all those categories are down. So that's good. Again, you're asking yourself, what's driving this claims cost? And it's large claims. All right. So the COVID breakdown, luckily COVID's almost over, but we do have some information on the COVID. Let me find it here. Here we go. So in 2021, the COVID diagnosis totaled $138,000. In 2022, $54,000. And then when you add those two up, the costs for COVID was $220,000. A couple other things I wanted to mention in along the lines of COVID. You had 1,548 members tested, 395 were actually tested positive, and then there was another 1,489 that were exposed to COVID. I don't have a slide here on this, but for your telemedicine, Teladoc had 8 claims for COVID in 2021 and none in 22 and 23. But as far as the Teladoc usage, you had 253 claims for Teladoc totaling $12,000 in 21. And then 595 telemedicine claims, which equaled 55,000. So telemedicine is being used a lot more than Teladoc. And the same holds true in 2022. You had 304 Teladoc claims for $15,000, 443 telemedicine claims for $43,000. I think I've already hit on that. Another stat I wanted to impart to you is that 95% of all your utilization, at least with Meritain, as far as our RAP network, was in network. So that's a good trend, and whatever communications you're doing to the employees is working. Do I have any questions?
Are there any questions? I have a couple. The COVID vaccine, I thought that the government was paying for that. So according to your chart, the plan paid altogether $37,223. Is that people who went
On their own?
outside on their own?
Yeah, I think so.
Did we try to, convey to people that they can get it for free, or?
Yeah, because the following year was only $5,500, as you can see. But I'll verify those numbers for you.
Right. Okay.
Madam Chair?
Yes.
Those also include the cost of administration, which wasn't covered by the government. They just covered the cost of the vaccine. But the costs associated with administering the vaccine are taken upon the plan.
Okay, great. That explains it. Thank you very much.
You're welcome.
Did you have a question? Okay, thanks.
All right, thank you very much. Appreciate your time, and I look forward to working with the county. Thanks.
Thank you. Oh, why is that happening? Where are we in the book now? We're flipping around here.
I'm not sure which piece.
567. Okay, tab 5, page 67. Thank you.
Good morning. So for those of you who I have not met in person, my name is Missy Jensen. I'm the Senior Wellbeing Consultant. I've been on the account, I don't even know how many years now, several, and it's been fantastic. So I work really closely with Leanne and the Mohave in Motion Wellness Committee, and it's just been fantastic having her leadership. So just wanted to say thank you, Leanne. And Ken, sorry. You too. So what I'm going to be doing is a very brief overview. We obviously provide you with updates on a regular basis. And so what I'll be doing is walking through pretty much just this slide, just to review the programs that we have in place today, and then kind of tee up a program proposal we have that will essentially help address some of our engagement opportunities we have for the programs we have today and the programs we don't have quite yet in place. So with that, as far as the preventive screenings and services go, these are in place to help obviously catch things in their early stages, right? So when we're actually catching them early on, treatment and care is going to be less costly and better for the plan and the member. We've actually seen an increase in all except flu for some reason, but I've seen that across the board with all of our groups actually. All of the screenings have started to increase or kind of rebound participation, which is a really positive thing. I think that's due to a number of factors, and I think Leanne, has done a really great job of communicating, emailing. I get CC'd on those emails on a weekly basis, so she's bombarding everybody with that information to make sure. Same with the Mohave in Motion Committee, so making sure that everybody's aware, pushing it, and so we wouldn't see that kind of participation if we didn't have her behind the scenes helping to drive that engagement. But again, really great to see that we're starting to rebound and bouncing back and increasing engagement in those screenings. I'm thinking maybe the flu vaccinations might be down as far as the on-site opportunities, because they're actually going to like a Walgreens or their pharmacy or getting it in collaboration with their COVID booster or vaccine. So that's something that I've seen with a handful of our other groups as well. So I don't really have an answer, but I can speculate that that might be why. Hinge Health is the new program that we had implemented back in July, and we've been doing fantastic. We have 99 enrolled in the chronic condition program. We have results from that program, so those individuals that enrolled in one of those chronic condition programs, and we're seeing some positive results. 48% reduction in pain, 77% decreased likelihood of actually having surgery, which is obviously a more costly route of service. So if they're actually going through doing the physical therapy programs, they're less likely to have that more costly service. So they're taking the more conservative route, which is positive. They test and actually, not test, I shouldn't say. So during those surveys, they also take into account their mental and emotional well-being. So anxiety has reduced. Depression has been reduced as well. So certainly positive things there. Members are enjoying the program. So there's a net promoter score, which is on a scale of -100 to a +100, and we're seeing a +56, which means members like the program. I hear often that Netflix is a 65, +65, so we're right up there, which is fantastic. So I'm happy to see that members are engaging, they're seeing positive outcomes, they're going for less costly care than it would be, obviously if they did like a surgery or pain medications. Any questions on either of those?
Does anyone have any questions? So how do we market that as these numbers come out? Do we let our employees know how much this is helping? Is it word of mouth? Like how is it being spread around?
Yeah, so we previously discussed with the Mohave in Motion Committee to get testimonials from actual members who have participated in the program and include in marketing opportunities moving forward. As far as what Hinge Health does, they do a lot of direct marketing, and we're in that, I think, second week of their marketing, so they do it on a regular cadence. So initially when the program launched, they pushed out their marketing, direct mailers, emails in collaboration with HR as well. So they have a set cadence and kind of a set marketing science, if you will, on how it's most effective to get members. But to your point, we definitely need to include member experience in that, in addition to those other tactics as well. So we'll work with.
I don't know much about statistics, but how would they figure that it would decrease the likelihood of having surgery? So is that like a survey they know for sure? Is it just some kind of formula?
Yeah, great question. And so it is all based on that survey feedback. How likely are you now that you've done the program, or prior would you have had surgery? So those are survey questions that they ask throughout of members who are engaging in the program.
That's very impressive.
Yeah,
number.
I'm excited. I'm excited to see where the program continues to go. Leanne and I actually had a meeting with Hinge Health yesterday just to talk about some new programs that are going to be available to Mohave County members. Because of the partnership between Meritain and Hinge Health, they're going to roll this out. They have a women's pelvic health program that will be offered, and there's also additional joints that they'll be offering as well, and it'll be computer monitoring, something you can't put a sensor on a pinky or, whatever. So they're going to roll out these new program offerings, and it'll be exciting to see how many more members are going to be able to engage and reduce their pain. It's very
Thank you very
exciting.
much.
Yeah.
Again, any other, go ahead.
I know those numbers are based on the people that are in the program, and that's a great reduction, but how do we reduce the other 1,000 employees that aren't in the program that are just thinking, oh, I got to go have surgery on my hip or back or whatever? Once they're in the program and we get those reductions, that's great, but we got to figure out a way to capture all those people who aren't in the program, whether they've forgotten about it, didn't know about it, don't know the success rate or whatever. We have to figure out how to get those people in the program so that those numbers will be reduced too.
Yeah, I agree with you. So we continue to market the program. I think we need to keep putting it in the forefront of everybody's mind so they know that this program is available. And then linking in those additional testimonials, I think, will be key. Word of mouth, obviously, is going to be really huge for somebody that might not necessarily sign up for a program right away. There's always those late adopters, too. And so I think if we constantly keep this in the forefront of their mind, we'll have that opportunity to engage additional members who might have just kind of waited to see how everything pans out with it.
Okay, anyone else? Thank you.
Absolutely. And then just to wrap up on the other program we have, so we have the Livongo Whole Person Solution. Again, I'm happy to report the engagement that we have in this program. Out of Berlin's request last year, I did include a more detailed summary on the eligible population and then how many are actually enrolled. So that's in the detailed summary in the appendix, and I'm happy to walk through that in further detail if you're interested. But I will say, as far as the members that have diabetes, they're taking an anti-diabetic medication. We have 47% enrolled, and this is without any additional cost share. That is fantastic. 20 to 30% usually will engage in a chronic condition management program, so seeing that we have 47% consistently is fantastic. Additionally, if you look in the appendix, we have the Livongo report. And you can see from there that we have more members that are in a more controlled glucose than they were at baseline. So we actually have a higher number of individuals in this program after 6 months who are more controlled, which is essential to basically prevent any additional comorbidities, make sure they're at lower risk for heart disease. So it's fantastic to see that this program is making an impact on those members who are enrolled in the program. And people seem to love it too. So a plus 56 net promoter score, meaning that they would recommend it to a friend or coworker as well. So I'm happy to see those outcomes.
Anyone?
Questions?
Doesn't look like there are any questions.
Awesome. So I'm not going to really go into the next slide in too much detail. It just essentially is highlighting those areas of opportunity and how are we addressing those. I already walked through Hinge Health being the MSK solution. Neoplasms or cancers, we obviously have the on-site preventive screenings, and then the circulatory disorders and then nutrition, metabolic, and endocrine are addressed through the Livongo opportunity. Mental and emotional health, obviously we have the Teladoc behavioral health and the EAP program. And I know in speaking with Leanne, constantly trying to push the employee assistance program, I feel like on a monthly or weekly basis. So she's doing a lot to push out those resources.
What was the change from last year to this year with the behavioral health? I know people are talking about behavioral health more, taking sort of the stigma out of it. We've gone kind of all in on this EAP. What are you hearing on the ground?
So Erin, I'm going to have you jump in on EAP since you are the one that implemented the program.
So, Madam Chair, could you just clarify your question? What are you looking for on the mental health?
Yeah, I mean, are you getting a lot more, after they start this, is there any way, or are they just, people don't talk about it? I don't think it's something people, give you an update on all the time, their mental health, but is there a way that we measure, is there any way you can measure whether this is really helping, or how long do people continue in the program?
Let me address that generally. So for Mohave specifically, actually what we're seeing is fairly low utilization on the EAP. I don't have Livongo stats on the psych portion of that. And Missy, I don't know if you do. I don't remember.
I could probably jump to it.
But we're seeing fairly low utilization. I would tell you, I don't believe that's a reflection of need. We have that problem that we've always had in Mohave and frankly throughout Arizona and even in the industry to some degree, is the low availability of providers. So we were actually discussing this morning with Ken and Leanne. We know that with the current vendor, 3 to 4 weeks is not uncommon to get in face to face. What's interesting in the statistics, and that's how we got onto that figure, is that for Mohave County, 70% of the EAP visits were face to face. So they're waiting to do that. I will tell you that across our book, I suspect that's part of the problem, whether it's unavailability or unwillingness to use an electronic means. We see the opposite. We see that 70% are done electronically with essentially whatever the FaceTime or Teams type element is. In general, I will say we are seeing an uptick in, and it's been sustained throughout COVID. Frankly, it was even pre-COVID with some of the addiction issues we were seeing with the various drugs that went through from meth to heroin to, on and on and on. But we're seeing a continued uptick. What we really see is a small number of highly intense illnesses, primarily substance, and then a fairly moderate number of lower level EAP type visits. I don't believe that need's going to slow down at all. I think if anything, it'll probably continue. It doesn't stay the same. It's not the traditional, I have a crazy teenager that's driving me up a wall, I'm having marital issues. The substance element to it has brought it to a completely new level.
Addressing the problem of providers in rural Arizona. This is something I know a little bit about, and it's a huge problem. And I was back in Washington, and they talk, and I know that there are these programs, tuition reimbursement, things like that, but they never seem to come to fruition. At what point does the insurance industry sort of step up and help out so it will save money in the long run?
That's an excellent question. It's the two-part answer. On the insurance side, when you think about insurance, including us leasing a network, the primary direction is at prescribers, people who have a medical license. It's not 100%, but that's really the primary thing they do. The EAP and the ancillary benefits will do those who are non-prescribers, okay? The short answer on accessibility is, I have not seen, in my 40 years working in rural Arizona, I've not seen a single vehicle that has been effective at increasing the number of providers in rural areas physically, period. I think the telehealth is really, it's the getting additional growing acceptance of telehealth is going to be the single best solution. Because even if you if you look at the overall number of providers available, the shortage is measured in the millions nationally. I think the last one I saw was 2.4 million shortage. I don't know how supervisors fix that one.
No, I agree with you. And, we're about to enter into a new program, our jail reentry. And I know that the only way that could work is if we have a really robust telemedicine factor in it, because that is the number one problem in the mental health industries here, is that we just can't get providers to stay. So, we're trying to do stuff. I'm actually speaking to our delegation out of Washington. Again, everybody knows there's a problem. It's just somebody's got to step up and at least try something.
And just to tag on to what Missy's doing, when she's talking about the program, the success on the diabetes and the Hinge Health and whatnot, those are essentially telemedicine programs. So I think we're creating a level of acceptability. It's one thing physical, another one psychological and whatnot, but I think it's creating an acceptable level. And frankly, I think the benefit of the pandemic is that we've all become a heck of a lot more comfortable with living our lives online. So I think the technology's improved dramatically. I think the uptake is following it. and I think we will see progress. Frankly, we're seeing progress now. I think we'll see greater progress as time.
I always thought that mental health was a natural for telemedicine, honestly. You're just talking to someone. In some ways, it's even better for some people with some mental syndromes and things. But has anyone here done the telemedicine through our insurance here? You have, and you have? I have too, and it was great. It was a great experience several times. And again, I think we have to kind of talk it up and the fear factor, and people don't, it's just we're so used to going, but there are some things, I'll give you an example. I mean, my life is an open book. I thought I had shingles, I had a mild case. Now, all I wanted to do was get it, someone to look at it and say yes, and then prescribe me something. It was like a 2-week wait at my doctor's office. So I did telemedicine, I put up my shirt, I showed them that, I did self-diagnosis and got the medicine that day. So it really is, it's nothing to be feared. If it doesn't work, it doesn't work. But I think it's, if used correctly, it's a great asset to have, and I hope our employees know that.
Well, and on that exact note, Madam Chair, Mike Cody just handed me a figure, and thank you, Mike. He said it shows that in the 2021 plan year, we had 107 mental health telemedicine claims through the medical plan, and 105 in the 22 year. And year to date, we're at 11. So 100's pretty good. We were talking in the car on uptake. Amanda and I were talking in the car on the uptake on EAP. It's not like, because of the difficulty, it's not like, and I've done the same thing you have, Madam Chair. I've done pink eye when we're on vacation. Like, really? But it was fantastic. But you don't get the volume with the mental health. So to see this kind of an uptake in the medical plan for telemedicine, in addition to EAP, in addition to what Livongo has, is actually pretty good. It goes back, makes me think of Missy talking about, don't worry about the on-site flu shots, because they're also getting it through the thing. So I think that's a pretty good indicator that there is uptake.
So these numbers are good as compared to your other plans?
That actually, I don't have one to compare.
Okay.
So I honestly don't, right?
Any other questions? Okay.
Okay, and I'm just going to wrap up by teeing up an opportunity we have with the a wellness portal, actually, to help with our engagement opportunities. So I do have Jeff Skelton here. He's going to go and do a presentation here in just a moment. But essentially, this portal would allow us to integrate all of the benefits and well-being offerings kind of in a one-stop shop. So that way we can maximize engagement and outreach to members, surveying them, being able to do additional pulse surveys essentially to say, how are you liking the program on an ongoing basis instead of just the one time of the year that we're doing it today. It would be able to have year-round tracking. So your nutrition, your fitness, and things of that nature. App integration, event scheduling. So really being able to, again, pull all of those details we have with our well-being program and benefits, you name it. So it's not just the wellness side, it's the entire picture, and having that one-stop shop to be able to link it all together, but then also have the opportunity to engage members in various challenges throughout the year and keep them excited about their well-being. I'm gonna pause there and actually see if you guys are ready to walk through with Jeff, or if you had any other questions for me at this moment in time.
Any questions? Very quiet today.
Just super thorough. And then I do just want to mention the fees. So Jeff does have it in his presentation as well, but at the bottom of the screen, I do have the fee structure. So there's a $3,000 implementation fee and then a $2.39 PEPM based on around a little over 1,000 employees. We'd be looking at $32,000. And then Meritain does have an eligibility file fee. We're waiting to confirm what that is, but it would be around 35 cents, not to exceed the 45 cents. Just that way we have that eligibility file going back and forth, so there's not any kind of gap in somebody being able to sign up and register.
Did everyone understand that?
No.
So I got a little lost.
Quick. Okay, so I'm so sorry. So the estimated annualized cost for the portal alone would be $32,000. And then Meritain does have a file feed fee just to be able to send eligibility file back and forth on I think it's monthly basis. So I just wanted to make sure that you're aware that it's not just the 32, it would be an additional, I think it's a little under 5,000. Ooh. All right, I'm going to get to Jeff's presentation. All right. Well, thank you so much. Appreciate your time. All right, that's all you.
Thank you. Good morning. I'm Chair, thank you for allowing me to be here today. I'm actually really excited about this. Hopefully we'll be talking about a fun topic and answer some of the questions you were just talking about, is how do we get people engaged in these different programs? And hopefully I'll shed some light on that. What I'm hoping to do today is not only introduce you to Navigate, but through that process talk about the evolution and kind of value of what well-being programs are today, and where we kind of reframe that. If we think back 5 or 10 years ago, when we think about wellness programs within any type of corporate environment, we think, oh, we're going to do activity challenges and Weight Watchers and that, and it is completely changed, and we'll talk about that as we go through here today, to where it really is now about connecting each individual to whatever resources are most beneficial for them, and it is creating this holistic approach, and we'll kind of talk about that. Just as an overview, my role in the organization is I'm Senior Business Development Manager. We also have an entire division of our organization focused on public and labor. We've been working with many of these different groups, and I share this slide just so you understand our experience and understanding your organization, and there's some very unique elements to working in this environment and with your employees. So for example, right now we're implementing for City of Dallas, City of Austin, El Paso. So we work with both small, medium, large organizations, and we're very familiar with that. Where that also helps us is with best practices, where we begin to find groups that are beginning to implement, because it all comes down to some of the questions you were asking was just how do we get people to participate? Doesn't matter how good the benefits are you offer or how good any of those are if nobody uses them. And so that's kind of our role, is how do we connect individuals, whether it be Livongo or Hinge or getting to primary care physicians or any of those are the type of things that we do. And it's through, there's some secret sauce elements we'll talk a little bit today within strategy, but it's also making sure that we're reducing barriers and making it very easy for individuals to, one, know what benefits are available to them, and two, access them, while at the same time having all the resources they need to be as healthy as they'd like. And I'll showcase one thing just because we talked about NPS score, just a little bit of our brag board there. Currently, our most recent NPS score was 78. And you see our customer satisfaction is at 94%, and well over 90% of our groups continue to stay with us. Matter of fact, I believe the significant majority of our clients now are on at least their third renewal cycle with us, which I find important, because it's one thing to encourage somebody to start with us, but when they can do a second renewal and even a third renewal. And you'll see that also has a lot to do with the way we developed our platform and our service, and that it is not a cookie cutter program. The program that we developed for your organization will be completely different than the others, because it is about building a culture of well-being. And so, as I always say, it's got to have that look and feel of your organization. And so it also matters when year two, right? Year two is going to look different than year one. We're going to take in the data, and we'll continue to evolve it in year 2 and 3 and 4 to make sure we're providing the most effective resources and communication plan and support for your employees. And that's really kind of ties into this. You know, we don't come in, if you're familiar with many wellness programs, it's here's how the wellness program or wellness platform works, and then you design your strategy based on what that platform can do. We've taken a completely different approach. It is very malleable and very personalized. So through the discovery process, we understand what are your goals in year 1? What is it you want to do, right? It might be we want to get people to their primary care physicians more. We want to get people that should be using Hinge or Livongo to get into those. We want people to have fun and connect with each other, right? That was really a big thing that came out in the last couple of years, is how do we get people to connect and create that social element? And then we'll begin to develop strategies and design the platform so that it can do that. A few items that as an organization and what we're learning based on the data we're seeing and feedback from our clients that we're focusing on this year is a very holistic approach to, as we say, total health and happiness. One of the things we learned over the last few years is being healthy is more than not being sick, right? It is about emotional well-being. It is about all those other elements. And so how do we provide support for the individual? Yes, with physical activity and nutrition, encouraging that with tools and resources, but also social well-being, sense of purpose, financial well-being, right? I always say if people can't figure out how to pay their power bill, the last thing to worry about is how many steps they took today. So we want to be able to offer them financial well-being resources or connect them to other things, whether it be, any social determinants of health that they can use. We're going to be able to provide that for them so that we, I always say, it's you do you, How do we support you on your well-being journey? And you're going to see that in a very holistic way. The other thing is service. We take great pride in our account management, and I know that sounds like, everybody's going to say that and put that in the brochure, but, we start on day one that you get assigned your account manager, not after you implement, right? And that person quarterbacks and learns all about the organization and then stays with you through the entire life of your organization. So the administrators are never going to call into a 1-800 number. They're going to have a single point of contact. Where that's important is this is not a widget that you set it and forget it. You don't just turn it on. We're going to learn. We're going to look at the data. How are they responding to communications or not responding? What challenges do they like? What are the surveys saying? As we continue to learn about it, then we want to make those, continue to evolve the program and make those changes throughout the year. So it's really important that account manager is intimately aware of your employees, the unique elements of it, even the key stakeholders and what their initiatives and what they want to get out of it. So that's a big part of it as well. You'll see it's experience to scale. So as I mentioned earlier, year 2 but potentially is going to look different than year 1, and so it has to be able to evolve. And finally, we really utilize data, not only in the data about how people are using it, but how are people, what challenges are they doing? What video learnings are they doing? There's some great information that comes out if all of a sudden you find there's a significant spike, for example, in elder care. Right? And you start realizing, hey, our employees are having a real issue, with caring for elder parents. And so then you can maybe kind of look and go, do we have enough resources for them? So there's a lot of information that can come out of understanding how individuals are using that. And we look at a lot of that. Not only do we provide that data for you on a regular basis, but something unique that we do is, as I like to say, we give you keys to the kingdom. If you've got, administrators that say, that's great, Jeff, that you provide report, but I just want to be able to go look at it myself. We're going to give you access to a real-time data dashboard and over 20 different reports that you can run at any given time. So it is completely available for you to see that data. Any questions so far, by the way? And I encourage you to interrupt me as we go through any of this.
Any questions? Roger?
I have a question. The data that you collect,
Yes.
Is it nationally or by state or?
It is
local data?
The data would be just for your employees, for Mohave County employees. And then there are the abilities to filter it. And this is where it really gets good into being able to communicate out. So you can filter it based on whatever comes through on the eligibility file. So for example, and I'm going to make this up, I want to look at transportation, right? Or I want to look at a particular administrative or whatever office you want to look at. How many people in that division are using in the last 30 days or any of that? You can filter that all, and then you could actually send communication to those targeted groups as well. So it's directly for your group.
Okay, thank you.
Yep, and it's all protected data, so nobody's personal information. What you're going to get is participation data or aggregate on, let's say hypothetically, we were either inputting or people were voluntarily putting in, let's say, blood pressure information. You're only going to be able to get aggregate data. You'll never see individuals' data on that. The next thing, and it's really a question that, answered that question you were talking about, which is engagement. As I said, it doesn't matter how good any of this is, even the programs that you offer, if nobody uses it. And so this is what we really do, and we really do well, is how do we remove barriers and make it very easy for individuals to access the programs? I've always said, and I've been doing this for more than 15 years, and I've always believed if we could just get people to use the benefits that are already available to them, they'd be much better served. Either they don't know where to access them or don't even know they have it. And that's where this type of environment makes it easy, because once they get in, I'll give you just a simple example. It's what I call the click around, right? They went on because they just wanted to look at the employee handbook to see what day they get off for 4th of July. And while they're there, they see this big, banner that says a new challenge challenge is starting, or don't forget about, Hinge Health, or here's a video of that testimonial of somebody that used Hinge Health that can be in there. That's not why they went in, but then they begin to see it and go, you know what, maybe I should, or connecting out to, let's say, an EAP, all from this one element. And so if we can, as I said, remove barriers and make it very easy for people to, one, be aware, and to access all the different tools that are available to them, it can be much better served. And ultimately, that's what it comes down to, is for the employee, right? And so as you can see here, and I've actually mocked it up, and if you'd like to see a demo, I've actually built a demo portal. When I'm finished here, if you'd like to be able to see what it looks like, happy to pull that up. But it really is a central hub, not only in providing resources to the individual, so whether they want to do challenges, and you can do group challenges for the whole county, you can do peer-to-peer. Madam Chair, I could challenge you to a 2-week step contest, and winner gets lunch from the other, right? We could do that, right? And that's what connects people, is those connections. And you can have unlimited peer-to-peer. We could challenge the whole group if we wanted to. And then there's individual challenges, things that I do for me. Maybe it's I'm focused on meditation, or I want to start journaling. There's tools in there to help the individual on their journey. So it really is about connecting them to all the things they want to do, and then also connecting them to the other things that you're available. And you can see in the visual, like on the right, if they wanted to go to Hinge Health or Livongo, those can be links out, or we can even do single sign-ons where they can go right into it. So truly bringing awareness and then removing all barriers so they can really go right to it.
So it's like a one-stop shop.
That's exactly what it is, yep. Yes, ma'am. And that's the second one, is that simplified and enhanced employee experience. I've run into people where they don't even know they have EAP, or they got to go find their employee handbook, which I would venture to say most people have no idea where their employee handbook that they got at open enrollment is. This makes it easy for them. We integrate all of our content, so all of the things that you might want to make available to them, whether they're digital videos or personal challenges or digital content about anything. I want to pick out the right pair of running shoes, or I want to, I've got high blood pressure. What's my first step? All that content is in there, and then we can even add more, or do personalized things, like if you wanted that testimonial video, we could embed that in there, or promote any particular item that's coming up. It's in there. There's a social wall. There's the ability for individuals to connect with each other and create subgroups. All of that is in there. And then the other really big one is communication, so that we can communicate, and the key for communication, in my opinion, I always say, is and. People are like, well, Jeff, do we put flyers up or do we send emails? Well, it's not or, it's and. Yes, you're going to put flyers and send emails and send this, and because each individual wants to be connected in their own unique way. And so you can even begin to segment that out. So maybe you want to, something as simple as, I want to send all of the March individuals a happy birthday message. You could do that, but you could also say, I want to send a message out to everybody that has enrolled in the challenge, or more importantly, I want to send a message out to everybody that has not enrolled in the challenge. You can, or just in a particular department, all of that is possible. There's an ad hoc messaging tool that not only do we provide a lot of communication, but we give that conduit that your team can send very targeted communications out to individuals to let them know about any particular event. Could be even open enrollment, could be don't forget to go to your doctor this year. All of that could be, and it's very targeted. What I also like is the individual tells us how they want to communicate. Do they want to get it as push messaging? And they put their email in. So if everybody doesn't necessarily check their, or doesn't have or doesn't check their, county email, they may put in a personal email, and that's where they're going to get this communication. And so we find a lot of groups that have not, what I'm going to call non-traditional administrative, right? They're not sitting at a computer all day. We're still going to be able to communicate out to them in a very direct way, and in the way that they tell us to communicate with them.
Again, any questions? I kind of like what I'm hearing.
Well, thank you.
Making it easier is always a good thing.
And that's the big thing. It's easier, and that's the evolution of wellness programs, right? It's not just for those that want to do a challenge. Because the other thing we understand about human behavior, and I've worked with a lot of counties, not only through, my professional job, if you will, but a lot of volunteer work and speaking. And what I realize is people want to be healthy. They just need a connection. And I'll give you a simple example. Madam Chair, you may have wanted to do a 5K walk, and you've always thought about it, but you never will until I say, well, why don't you come with me? I signed up for one. And then you do. And people a lot of times are looking for that type of engagement and connection to help them, where we've talked a lot about today, word of mouth. But how do we create a conduit for communication of word of mouth? And it's through things like this. Just the last couple slides here I'll share with you. I talked a little about data. You're going to see we're going to be providing you quite a bit of data on usage, and what I'll encourage you as time goes on and you look at the data, it's not always, I don't ever say it's bad data. We still learn, right? And I'll give you an example, like, oh, we did a step challenge and no one participated. Is it that they're not engaged? Or is it, and an example, no, because you're in Milwaukee and you did it in December. Like, bad idea, right? Right? It wasn't that the challenge was bad. Maybe the communications were bad. We're going to learn from it, right? Maybe it's a hydration. Maybe come June, it's a hydration, encouraging people to drink more, right? So it's not all of those standard, let's take a step challenge. The other thing is allowing, goes back to what I was saying, is you do you. Right? I think where a lot of these programs in the past have fallen is like, you only do step challenges. That's great, but I swim or I ride a bike. Like, why can't I do my journey? Everybody's on their own individual journey, and we really try to encourage that, of let each individual pursue their own journey towards better well-being. The last thing I'll share with you, also on our well-being app. So we're going to make it not only available on desktop, but also on mobile app, and that's through either Android or Apple devices. And I'm happy to share that we have, for our mobile apps, not only an English version, but we also have Spanish versions for each of those as well. And then on pricing, and as Missy mentioned, we try to keep it pretty simple. It is a PEPM, so basically $30 a year per employee. So basically, for the cost of taking each employee to lunch once a year, they get access to all of this in a very simplified way, and all of the tools that they may want for their personal well-being journey, whether it be, like I said, for just themselves or connecting with others. And it's not only about physical activity and nutrition, it is about emotional well-being, connectedness, purpose, all of those different elements as well.
Right? Nothing?
Yeah. Madam Chairman, when you have an open enrollment, I think this is a question for HR, do you still have open enrollment wherein the employees are given information on different programs or the benefits that the county offer? I mean, not just open enrollment passively, but do you all get together and there's some information?
When we conduct open enrollment, this year our plan is to have it here in this room and video it so people can watch it at their convenience, and it'll go over each and every step of what the plan provides, what is new or different from the previous year. This year we're looking at pretty close to a positive enrollment, which means everybody touches their benefit plan. So that way we can get everybody involved in the enrollment this year.
Thank you. I think that's a very important communication with the county employees. It's different sending it by email or electronically, but if you have the open enrollment, then they're able to talk to representatives or even people in the programs and how it works, and that interaction is very important. Thank you.
Yeah, I agree wholeheartedly, and that's the first step. And then it's like, okay, now what happens in 3 months when I think about it? How do I make it easy for me to find it in 3 months? Yeah. And we can help support. We work with a lot of groups. Obviously, the communication for open enrollment, we can do it through here, sending out targeted communication, reminders, banners on here, even the scheduling. So if you want, let's say you had 2 different meetings and you wanted people to sign up for those, that can be done on here as well, on the site.
Okay.
Any other questions or?
Roger?
Yes.
A question on, there's so many different wellness apps out there now. You got your Apple Watch, you got Fitbit, and they're getting more and more into the depth of health. So people that use those apps, would they be more likely or less likely to get involved in a program like this?
It's a great question. I'm glad you asked it because I did forget to mention it. We sync up with all of those devices. So whether you're using Fitbit, Garmin, Polar, or apps like Runkeeper, that data you do there funnels back into here. So they work really in conjunction with each other. So let's say you're participating in either a peer-to-peer or a group challenge, and let's say it is steps, and I have Runkeeper that I use personally, or let's say I'm using my Garmin, those steps will go in here. So we find they're much more likely if there's a compelling and exciting reason for them to want to participate in it. But they do sync up. Matter of fact, we are the wellness program for Garmin, for their employees. So a little little brag on that one. Because I think that's important, right? Because Garmin works with everybody, and yet they chose Navigate to provide this for their employees. But yeah, we sync with over 100 different devices, so whether it be your Apple Watch or whatever, it syncs directly in here. Thank you for asking that. Yeah.
Quick question, we would be signing up for a 2-year commitment?
Correct, it's a 2-year agreement, and then there's renewals that can come pretty easily. And the reason we do that is because we find the first year, that's really the build up to it, and we learn a lot in that first year, and then we make the changes for the second year. But a lot of the energy is really applied in building that site initially.
Okay.
Thank you for your time, appreciate it.
Okay, so now we're moving on to Blue Cross and Blue Shield of Arizona overview, discount and utilization review, tab number 7.
Good morning, Madam Chair and trustees. So good to be back here to see you guys today. And I will keep it short, sweet, and brief. I think we're a little ahead of time, but I'm happy to share with you a little bit about what's new with Blue Cross and then talk about the discount positions that we're providing to you all and continue to provide to you all. So quick agenda. I wanted to share with you some new members to our team. So you might have remembered Mike Greger. He travels along with me on our road show with the Gallagher team for all of our trust meetings. And then new to my team is Kevin Scott, and additionally new to my team is Washington Covina. So new at Blue Cross, what we're doing is we're building a new sector, if you will, public sector. We're focusing on municipalities, public schools, manufacturing, tech business. We've got lots of companies coming into the Arizona market, so we're really putting a focus on those types of customers because the needs are different, and we feel that if we have the best all-star team that manages and focuses on that, we'll be able to bring best-in-class value to you all. So just wanted to share that, and my contact information is there because the next piece I wanted to talk to you guys about is our foundation. We launched the foundation, which is a separate 503c at Blue Cross Blue Shield of Arizona, January of 21. So last year, I was unable to share with you guys all the good stuff that we're doing, but the primary focus, and I've heard it on everybody's presentation this morning, is mental health. So our primary focus, we have 4 pillars that we're focusing on, and that would be our chronic health condition, which is a focus in area around diabetes, because we know 1 in 9 Arizonians are pre or diabetic in this state. 2 would be health equity or social determinants of health. You heard that from our guest right before me, is that there's really a focus on, healthcare deserts such as rural Arizona. So, and it's driven by the zip codes that we live in. Do we have access to care? How are we going to get access to care? The third pillar would be substance or mental health, which is a huge focus for us. We learned so much coming out of COVID. So we are committed to our primary focus in mental health. I'll talk about that in the next slide quickly. And then the last is substance abuse, which is our opioid epidemic that we have in this state. And what we're doing, the bottom here is our grant process and application link. So if you take anything away from me today, I just ask that you take this link in the grant process, because we just closed our first series March 6th, but our next round is coming in May. And then we have a third round coming in August. So to take anything away, we have dollars to provide for organizations within your communities that are doing good work in any one of these 4 spaces, whether it's mental health or substance abuse or diabetes. So I just encourage you, I would love to come back here in a year from now and say we were granted, a number of dollars to Mohave County to support organizations that are doing good work in this space. I have my contact information on that previous slide, so if you have any other questions, please just reach out to me and I will be glad to direct you in the right area. But mental health is a primary focus for Blue Cross Blue Shield of Arizona. I heard Madam Chair, your questions on what is the insurance carrier doing in this space? And it's a national epidemic. As you know, in DC, there are not enough providers in our country. Not enough folks are graduating from school that want to practice and partner with insurance carriers. So we're dabbling in value-based reimbursement contracts at Blue Cross Blue Shield of Arizona for our behavioral health partners. So it's a tit for tat, like let's put the dollars where we're improving that mental health for those members, and which includes focus on access to children, as well as reduced times to get in to see the provider, leveraging telehealth so that they can see and have the telehealth component with our Blue Cross Blue Shield of Arizona providers. So those are 3 different ways right now that Blues are looking in that space to encourage providers to be part of our networks. We have a 5-year commitment to, or $5 million commitment in this space over the next 3 years to really leverage mental health. So I'm hoping again that I can come back a year from now and share with you what we're doing in that mental health space. It is important for all of us. It's important to me. I feel it, COVID really, it was an eye-awakening to a lot of people, including myself. And I wanted to share with you guys so far with our foundation launch in 2021, we actually provided over $200,000 just to Mohave County in 2021. So again, if anything, take anything away, I would love for anyone or any of our folks to provide or apply to our grant so we can provide you dollars for encouraging and continuing to do good work that you might be doing in your communities. This is just a snapshot of some of those grantees that were awarded dollars that focused on behavioral health. If you go to our site, there's a breakdown of every single one of those 4 pillars. These are just 3. In 2021, we provided $2 million to 90 grantees statewide. So you will see on our site, it will show you if it's a statewide grantee as well as a specific county. So here we have Children's Arizona Association that deals with youth age 16 to 22 related to mental health diagnoses, and it gives you their specific link. That is a statewide program where they can access healthcare providers or resources at no cost. Not My Kid is a focus for those folks that are struggling in the transgender arena and behavioral health issues. Again, an awardee, a grantee from the Blue Cross Foundation. And then lastly, providing residents of Colorado City expansion and development of behavioral health and mental health services here in your county. So you ask what we're doing, we're reaching out and utilizing our levers here in our foundation to help spread and encourage services for residents statewide. One other thing I wanted to chat with you guys about is that, times are changing. What's new with Blue Cross? We know that there's a focus on mental health, and we're really trying to transition our organization into a health solution company. What does that mean? Right? Just break it down, Rachel. What does that mean? So we kicked off for our house account, which is Blue Cross Blue Shield employees, a stand-up clinic. A stand-up clinic, advanced primary care clinic. So think about it as a tiered approach. So we have about 800 employees out of 2,700 at Blue Cross of Arizona that have elected to use our Persano Health benefit line, Signature Persano Health. It's advanced primary care, same-day service. You have primary care as your primary physician, but we also have pharmacy, radiology, behavioral health specialists within that clinic, if you will. And they are Blue Cross Blue Shield employees. So we worry about how are you going to get providers to stay. They're our employees. So the plan is we just launched our first one for the house account in January 1 of this year. So we're kicking the tires, working out any of the kinks. We are launching 3 more in 2023 in Mohave County. It's going to take the 4 corners of Gilbert, Mesa, it's in North Scottsdale, and then good year, and then we're branching out into rural. I have been an advocate to get us up here for Mohave County. So stay tuned, because I think, again, when I'm back here in a year from now, I can share with you guys what the planning is for future, because we're going strong with building them out for 2023 in the Phoenix MSA area, but we're coming. We're coming to the rural parts of the state. We know it's important. So you've chosen the best network partner, and I wanted to share with you guys the financials. So this is just a high overview of the claims that have been submitted to Blue Cross for pricing. We had about 24.6 million claims come to us. Our strong discounts provided our contract amounts at 9.8 million. That realized a discount or savings to the county, 14.7.
Can I just interrupt for a moment?
100%.
Our handout and the screen is cut off. Is there any way to shrink it so we can see the whole thing up there in IT land? You have any influence there, Sam?
Control F.
Oh, okay. All right. Oh, see, it's coming there, but we don't see it on our screen, and it's not in our books.
Oh.
I think that there's some information that we need context in.
Yes, so I don't.
I can't really see that. I know, but I know. I only can see that, but it's far away, and it's too small, the type.
I gotta see what you're seeing.
Okay, yeah.
I don't know how to help.
Yeah, but come here. But come here.
We're not seeing that here.
We got
This one.
this, and this is cut off.
Oh, it is, okay.
Yeah, so, and that, they can do it. We've had this issue at the Board of Supervisors. I think that they could do it up there. I don't even know if they hear me now. Well, that would be nice. Get your exercise, get your steps in,
steps in.
Erin.
I don't know if they can adjust these monitors because the monitors we run into that.
I think we did, though. Didn't we do that at like 2 meetings ago?
I think they can make the actual slide smaller.
All right, let me.
All right, well, let's see.
The screens are.
Ah,
How's that?
that's much better.
Okay, perfect. Yay, we can see numbers.
Thank you to our marvelous
Thank you.
IT department.
The IT gods, thank you. All right, let's jump back in. So our Blue Cross discount provided the county a 60% discount off of billed claims. And 1 percentage point of that discount represented about $246,000. So just wanted to call that out. That's the most valuable piece on this slide when I'm talking to you guys about the discount. The next slide that I wanted to take a deeper dive is, of that savings, where are we seeing that? And we call it place of service in our industry, inpatient, outpatient, and professional services. So the 45% of the 14.7 million was from your outpatient services. That was the same for last year, so it's carrying over. And what I'm thinking is happening, I don't see all of the detail on the claims, that's for our Meritain partners, but I'm gathering that high-cost claimants, cancer patients are driving this cost. A lot of those costs are driven in an outpatient setting. So the discount applied to just those outpatient claims was about 54%, and that equated to 6.5 million in savings for the trust. It was a slight decrease from year past, but again, it was the same primary driver from last year. So it was a 6% discount from last year, 9% discount from claims, and then just a slight discount in reduction in the discount position. So last year we had 55%, this year we have, last year we had 50, I can't read it, so small. Isn't that horrible? I need glasses. 55%, and this year we had 54. The next piece here is just a breakdown for you guys of the total savings that the Blues provided for the trust. What I'm trying to share with you guys at this point is the access fee that I ask for every year, which was a reduction since our RFP, is only a smidge of your overall cost. So the Blue Network is giving you folks 14.7% discount. Our contracts are providing you 9.8 million in savings. Our value is that 264 $100,000 for just 1 percentage point of our network, that 60% I talked about in the beginning. And what I'm charging you is $180,000 a year. So about 2% of your overall cost for that. Here's a summary of just the county's total billed. So again, 60% in savings. The outpatient savings by claim type is driven by your outpatient services. Claim distribution, this is always fascinating to me because we have 96% or 95% of your claims that come to us are driven by PCPs, specialists, and then we had 14% for outpatient, which was exactly the same for last year. So the far bottom left just gives you the discount by each one of those categories. So inpatient, the county is realizing a 66.5% discount, outpatient at 53.6, professional at 65.9, and then an aggregate 59.9%. Summary to the right, we're just showing a decrease in what was billed from the previous year, almost a 6% decrease there. Slight discount increase from last year. We were at 59.7, this year at 59.9. Increase in your that should be a decrease, that's a typo. 6% decrease in savings and a 9% decrease in claims. The next slide, for some reason it's not going. Okay, there we go. This is just a 5-year trend. So your 5-year trend, on average, the Blues are providing you a discount of about 58% off of total billed charges. And then you'll see the reduction from our access fee from 21 to 22. That was the beginning of the RFP. We're now in second year of our renewal for July 1 of this year. So we just have a 1.3% increase for that access fee. We're charging you $15 right now per month. So we're going to 15.2, so $15.20. So I think that was it for me, and if you have any questions, I'd be happy to answer them.
Thank you. Any questions?
Thank you, everyone.
Rachel, I'd like to, would it be possible for us to get together and talk about the plans you have for behavioral health in Mohave County and the best places? Because there's so much going on, and trying to make sure that there's not
I would love to.
Overlap.
I would love to.
Okay, we'll make that happen. Thank you. Yes.
Question for you for the foundations. The eligibility for the applicants are only 501c3s?
No. It's anyone in our state that is eligible for the grant.
Okay, when you say anyone, any organization, government, private?
That is correct. All of the details are listed in our grant process, and Susie, I can share with you that link there goes into explicit detail of, there's a letter of interest, there is what type of pillar you'd be interested in, the designation of your organization, the contact for the organization, so it goes into explicit detail.
No, a government can also apply?
Mm-hmm. That is correct.
County and cities?
That is correct. We service counties and cities throughout the state, whether they're customers or partners. So there's no man left out here.
All right, thank you.
You're very welcome. Thank you very much.
Thank you so much. Prescription drug utilization review, and that is tab 8. 8, yeah, that's it.
Okay, I think we are in the right section here. Good morning, Madam Chair and trustees. I'm Lisa Thompson. I'm a Senior Client Services Executive, and joining me today is Jake Gohl. He's your Clinical Account Executive. We're both with Navitus, and we manage your pharmacy benefit. So we're here to talk to you about your pharmacy trend or spend, and you will see on the bottom of this slide, the 2 timeframes that we're comparing is the second half of 2022 over the second half of 2021. So when we talk about the different figures, just know that it's the second half of 2022. So for your pharmacy spend, your plan paid was $1,599,000, and it did increase by 54.4%. And we will talk about that. That's primarily attributed to some specialty medications, and Jake will get into that level of detail for you. Your plan paid per member per month, it was $122.52, and that also increased by the same about 50%. And your per member per month is taking that plan paid, and it's the time frame that we're looking at, the 6 months, divide it by that and divide it by your membership, and that normalizes the data so you can compare yourself to other customers or clients that we have. And you'll see that sub-bullet point, that public sector book of business, so similar clients that Navitus has, you can see that their per member per month was $168.79, so you were well below that. The next bullet point we look at is your generic dispensing rate, and we typically want that to be higher because generics are typically less expensive. And so your generic dispensing rate was 82.9, increased from the time period prior, and it is above our book of business as well, so good work there. And then we also want to look at that fourth bullet point, that's our specialty percentage of plan paid, was 55%. So those specialty drugs or those higher cost medications for chronic conditions and where the cost really can be driven in the pharmacy benefit. And you'll see that that was an increase as well as we talked about in the two top bullet points. And when you look at the sub-bullet point there, you're very much in line with the book of business, which their specialty spend is around the 56% range. Okay, this key performance metric slide is a little busy, but it is a great snapshot of the costs for your time frame that we're looking at. So just in the eligibility section, you can see the average invoice members per month did increase a little bit. Percentage utilizing members was about the same. The member cost share did decrease a bit. That's the amount of the cost share that the member takes as compared to the plan. Your utilization was very similar in the total scripts that you can see, and the utilization day supply per member per month. So how many prescriptions did each member take per member per month was very similar as well. The drug mix, we already talked about, your generic dispensing rate and your specialty percentage of plan paid. And then the bottom half of that slide really tells a good story. So your average wholesale price cost with dispensing fees and taxes, so that's what the pharmacy is charging you for the prescriptions, was $3,448,000. Then you add in the administrative fee, so what you pay Navitus for the work that we do on your behalf was $29,761. And then what subtracts from those costs are the network discounts, so the discounts that Navitus negotiates on our client's behalf was $1,683,000. And then we also subtract out what the members paid, the $128,000. And then other payer amount, you'll see that $37,562 figure. That is coordination of benefits, so other coverage that might coordinate with the benefit that they have with the county. And then we have Copay Max, which is a copay assistance program, so that manufacturer's assistance that's utilized as well, also takes away from the cost. So you had an overall pharmacy benefit cost of $1,629,000 and a per member per month of $124.80. And this slide is the only one with that administrative fee factored in. So are there any questions so far? Board, any questions? Okay. You have a question? Riveting, I know, so. So we'll just talk this, I gotta do the slide. This one just shows in a nice little column chart fashion. You can kind of see what drives the cost. So you'll see in that lower right, the price inflation and the drug mix. So the drugs that went into this time frame are really what drove those costs. And on that lower left, you'll see it really is specialty drugs. So with that, I'm gonna turn it over to Jake and he'll give you a bit more of that detail.
All right. Well, thanks for having us here today. It's great to see you all for the first time. I'm going to jump more into the clinical details for the plan for this time period. So we're going to start out with just your generic versus brand utilization here. And you can see your trend fairly closely follows our book of business. Your line is above that yellow line there. So sitting above book of business, which is nice to see for that generic dispensing rate. Generally, the reason we see the dips in particular quarters, or those were quarters where we saw higher COVID vaccination rates. All of those vaccines are brand name. And generally in the third and fourth quarters as well, we'll see dips in that rate just because that's when people are getting their flu vaccines. This slide, just very quickly, is a high-level overview of your script costs versus script volume. So you can see there that the majority of your script volume are those medications that are under $25, which is something we do like to see. This slide also does highlight how those specialty meds do have a big impact on the plan paid amount. So while it's a very low volume of drugs, it does account for the majority of the cost in terms of plan paid. So your top categories by plan paid here, and my next slide is going to get into the individual medication that's really driving this, but your anti-neoplastics or your cancer medications are coming in at number 1 there. And then one I do just want to highlight as well is your miscellaneous therapeutic classes. This is driven by a new start on a drug called Revlimid. This drug can be used for a variety of conditions, which is why we lump it into that miscellaneous category, but generally we see it used for specific blood cancers or other blood-related conditions there. And that is a very high-cost specialty drug as well. So here's the magic slide that's going to call out that one drug that really drove costs, and figured that would probably be what I spend the majority of my time talking about on this one, as you can tell by the bullet points. So it is this drug coming in at number 1 called Semblix, and it's used to treat a specific type of leukemia with a very specific rare mutation. So the other issue with this is the cost per fill you see there comes in at about $92,000 a fill. One of the things that's driving that is with this specific mutation, it requires a very high dose of this drug too. So the normal dose for the other diagnoses of this drug is just 2 tablets a day. When a patient has this very specific mutation that this member had, you have to take 10 tablets a day. So that is kind of an unfortunate cost driver there. I will say I was looking into our prior authorization team who reviews this before we authorize payment, and they did excellent due diligence on this. They confirmed the appropriate diagnosis. They confirmed the genetic test had been completed and received the actual results from the genetic test. This member had also tried and failed 4 other medications before this one too. So basically they had exhausted all of their options. This was a bit of a last ditch effort here. And so with that, they did only end up getting 4 fills. And from what I can see, they did end with the plan in October. So moving forward, unless there's another act of God, should not see this medication being filled anymore, at least for this member. But another thing to call out on this slide is there were just a few new starts on other specialty medications as well. So you can see the Skyrizi there had 3 members start on it, the Revlimid, which I had already talked about, and as well as the Tremfya at the number 10 spot. So just seeing increased specialty utilization across the board for the plan. And this slide is just going to give you an overview of your specialty conditions. So not a wide range of specialty conditions. That chronic inflammatory disease is capturing those drugs like the Humira, the Tremfya, and the Skyrizi. But again, specialty percent of plan paid sitting at 55%, which is still just below the book of business there, which was 56.5%. So before we keep moving, are there any questions so far?
Any questions? I don't know if this is the right time to bring this up, and I don't even know if you can answer it, but there's a lot of talk out there about lowering the cost of medication for diabetes. Are you going to address that later, or is that?
That's something I can definitely talk about. Yeah, so I don't know if anyone saw the recent press release by Eli Lilly regarding their insulin cost reduction. So they slashed their prices by about 70% on their insulin. Currently, just because of how the pricing was set up before, Navitus did prefer Novartis insulin instead. So the Novo Nordisk is the manufacturer. So the Novolog insulin as opposed to Eli Lilly's insulin. We are waiting to see how Novo Nordisk responds to that. We do expect, in order to remain competitive, they're going to have to do something similar. If they don't, I can tell you that our formulary team will certainly be reviewing the Lilly products and determining whether those should be added, just because we're always looking for the lowest net cost product to have on our formulary.
Right. And is that a big cost of, I don't know what insulin goes for, but has that been historically a large cost for the trust?
Insulin has been, and then there's a new class of medications. I'll go back to the slide here. A few of them are highlighted. So you can see on here, it's the Trulicity and the Ozempic. Those are gaining a lot of popularity in the diabetes space right now just because they're very effective at treating a lot of the conditions that come along.
And they advertise a lot.
Yeah, they do. They do a great job of that. But in terms of diabetes, they're also, as you probably know, very effective at helping with weight loss. And they recently received FDA labeling to say they also help reduce the risk of heart disease and heart failure in individuals with diabetes. So with those, I like to say you're getting some bang for your buck on those and helping with some of those co-conditions that do come along with diabetes. The benefit of those drugs being brand name, usually you don't think of brand name drugs as being beneficial just because they're so expensive. But since they are still under one manufacturer, they are rebated. And with Navitus being a full pass-through PBM, every rebate dollar we get back gets sent back to the fund. So we don't hang on to any of those rebates.
Okay. Yes, Berlin.
I have an off-the-wall question. When we have a patient like this that has such a high need for something that's so expensive, is it possible for the county to go out and purchase a different insurance plan for that particular person?
So that would largely start to fall on the responsibility of perhaps the member or the county. I can say that within Navitus, we kind of have a way of doing this, and that was actually something I was going to get into in some later slides here. But there are, with our specialty program, something that we call Copay Max Plus. And with that, our specialty team will reach out to pharmaceutical manufacturers and essentially leverage the savings that they have available. A lot of these manufacturers do offer fairly substantial savings on these specialty medications, and that's the job of our specialty team and our Copay Max Plus team, is to find these opportunities out there. I can say for Semblix, though, not a very widely used drug at all. I think this is the first time I've ever seen it used on one of my plans, and I was looking into our Copay Max Plus drug list, and currently it does not look like the manufacturer offers any discounts on this drug. I will say the benefit of having the Copay Max Plus, though, is that there are a wide range of specialty drugs on there, and you think of that as almost having extra insurance. So if a member does happen to end up on one of those medications, we are able to leverage some savings that are available through the pharmaceutical manufacturer.
Anyone else? Thank you so much.
All right, and speaking of, so Mohave County currently uses our Copay Max program. The Copay Max Plus one I was referring to is a little bit newer, and I'll get into the details of that here in just a second, but wanted to call out that through those savings programs available for Copay Max, we did leverage just under $32,000 worth of savings on these specialty medications, 9 utilizing members across 44 eligible claims. So the reason I bring up Copay Max Plus, and that being a newer program, is that it's a pharmacy agnostic program. So we have access to all pharmacies as opposed to just our Lumacera in-house pharmacy, which is what our Copay Max program uses. So by leveraging those other pharmacies, we're able to capture a much wider basket of drugs that have savings available. Additionally, with the Copay Max Plus program, we lump the HIV medications into that as well, and those are very high cost medications. I don't believe I saw any members on your plan utilizing them right now because they usually jump into that top 10 category. But it's just nice to be able to capture those extra drugs with the Copay Max Plus program. So that is a potential solution that we could entertain if we wanted to find some potential additional savings for the plan. And Finally, I just have one more slide here just to look at some cost drivers moving forward. So the magic word through this entire presentation has been specialty medications. That's what every pharmaceutical manufacturer wants to make now, just because that's where the money is. And you're seeing increased utilization of these specialty drugs. So again, with the Copay Max Plus program, that's Navitus's big solution to kind of help tackle these costs with the new specialty drugs coming to market. Additionally, one just to throw on your radar is gene therapy, which is also gaining popularity as well. So there was a new drug called Hemgenix that was just approved that actually is said to cure hemophilia B, first of its kind. The issue is the price tag. It's $3.5 million for a dose. And I will say that that's usually the response it gets. Navitus currently has it set up to where this drug won't even pay in their system, so there wouldn't be an accidental claim going through for this. Additionally, since it's administered in a prescriber's office, it's unlikely that would go through the pharmacy benefit anyway. That would likely be directed to medical benefit, but just something interesting to have on the radar. The more exciting side is the cost reduction factors. So with biosimilar, which is essentially just a fancy name for generic for biologic drugs, you might have heard about Amgevita, which is the biosimilar for Humira. That was just launched at the beginning of February, and Navitus determined that we will be adding this to our formulary. We do expect to see these Amgevita claims costing about $1,400 less per claim when compared to Humira. So it's nice to see there will be some cost reduction in that specialty space. I feel like I've already talked a lot about Copay Max Plus there, so don't need to go into too much more detail, but happy to answer any additional questions on that. And then finally, enhanced rebates as well. Again, as I had mentioned, you see increased utilization of those brand name drugs, those specialty drugs. The one benefit of having them still under patent and still brand name is that those manufacturers do offer some decent rebates, which again, we pass through to you, all of those savings.
Excellent. Thank you. Question? Yes, Roger.
Got a question, just kind of off the cuff. The specialty drugs in the United States and the costs that we pay compared to other countries. I see that on the news every now and then that it's exorbitant. What's your experience with whatever knowledge you might have?
Exorbitant's a good word. I think frustrating is another good word. It's very difficult to see these prices come through and thinking to yourself, is it worth it? I can say, just kind of off the cuff for myself, one of the reasons we maybe see this in the US as opposed to other countries is because we allow the direct-to-consumer advertising, those TV commercials for these drugs. There have been studies that have shown these pharmaceutical companies spend as much or more on marketing compared to research and development. So that is just one of the unfortunate side effects of that in the United States, being one of 2 countries that allow advertising of drugs. So my guess is that's one of the main things that drives the cost in the US compared to other countries.
I was really curious about that hemophilia drug.
Yeah.
So, you're a patient, good news, they have a cure, bad news, you're never going to be able to afford it. I mean, who would pay for that? I mean, who would eat that cost? Is it like experimental under like a hospital?
Yeah, so I would expect to see that administered in a hospital setting or a medical office setting. They're going to be seen by a hemophilia specialist as well. These patients who have hemophilia are all connected with specialists.
Sure.
So yeah, that's we really haven't seen claims coming through for this yet at a large volume, especially Navitus wouldn't, just because they wouldn't go under the pharmacy benefits, and I haven't heard too many rumblings about it being administered outside of clinical trials at this point. That being said, it does have the FDA labeling, so it technically could be. I just don't know how medical carriers have set that up under their plans as well. But my speculation would be with rebates available and being that it's under patent under one manufacturer, I would hope that the pharmaceutical company would be offering some substantial assistance there.
I'd be a little upset.
Yeah.
Yeah, so Madam Chair, that's a good point. We actually have an option in the renewal to price these, to add it. And frankly, it's at the request of Meritain. They've had some litigation in the past where clients don't cover it. The plan doesn't currently cover it.
No, I understand.
Chris ran some pricing on the actuarial side, but just as kind of an FYI, we're not going to recommend it. But there's a requirement from Meritain each year that you don't add it, that you sign off saying we actively considered it. The challenge with a drug like this, and I was with Gallagher's pharmacy benefit consultant who actually did the RFP. I had a conversation with him, asked him about that. So, talk to me about that. It's ironic that he and Jake picked the same example of that drug, and it's a hereditary condition. And I don't know if he dealt with it or if it was his example, but he had a family of 4 with it. And all 4 went with that medication on one plan. So last year when we did this, we asked the stop-loss carriers, hey, what would your charge be if we added this benefit? And they said nothing as long as you don't have one. If you have one, we laser it. So we will not take it. So if you come in and you don't have one on the plan, we'll take the risk one time. But then the minute you have one on the plan, we'll put a laser on that person. We won't provide any coverage to them. So essentially you could, and it's not a far stretch. It is conceivable that over even a 5-year period, as the number of these drugs multiplies the number of, because they're kind of, I don't want to choose, they're not orphans, but they're serious condition, not that prevalent in the population. It only takes 1 or 2. And your surplus disappears, right? So that's the dilemma, right? You want to provide the medication, particularly if it's curative. They're not always curative, right? But if they're curative, you go, okay, that's a great deal, but you wind up essentially putting the plan upside down. So it's a terrible challenge because of the obscenity of those prices.
I'm not sure if I'm speaking in turn, but I believe hemophilia is more prevalent in the African American community. Do you know anything about that? As I say, that is health equity. Honestly.
I'm not sure if it's hemophilia or if that's sickle cell.
Oh, maybe it was sickle cell.
Yeah, I think it might be sickle cell. I haven't heard of hemophilia.
Anyway, I just thought that was really interesting. Okay,
definitely.
Thanks. Okay.
That's it.
You did a great job. Thank you so much.
Thanks for having us.
Very interesting. Now we go on to dental claims review, and that would be tab number 9. We're just flying through this today.
Good morning, Madam Chair, trustees. Happy to be back again this year. I think I was on the phone last year and we had a little bit of a disconnect, or it was hard getting signal, so I completely understand the in-person meetings. I just need to go to my PowerPoint, or is it down here? Assistance. Assistance needed, please. There you are. Thank you. Okay, so basically this particular dental plan offers both a high and a low plan. So my report is going to be a brief overview of the both plans. I know we're trying to just keep it as simple as possible, so bear with me. I'm going to start with the high plan executive summary. And one of the things notably I'd like to point out is that your preventive services, cleaning exams and x-rays are over 40% of your claims, which is a good number to have. Our book of business typically sits about 39 to 40%, so you're right in range. And some of that could be attributed to the wellness prevention programs that are offered through the county. I know we do a drawing on a quarterly basis for those who go in and submit the proof of their clean exam and x-rays. So they are mailed a nice electric toothbrush, and we're happy to be part of that just to encourage overall wellness. Your claim payments compared to the year before were $174. They're this year $161, so they did go down a little bit. But if you look, I know it's a little bit hard to read, utilization did go up. So the average claim cost has gone down. It could be that there are some people that didn't need a lot of major services done, or basically the discounts that are being offered through the utilization that we see in the PPO network. Your overall participation.
Excuse me, and do we have that in our book? Yeah,
It's
we
the
didn't
second-
have that last slide, which has all the information in our book. Maybe you can provide it to us at a later time.
Which is, you don't have the executive summary?
Yeah, we don't have that in our book.
They don't have. Okay.
This is just the master presentation. The executive summary is probably behind the presentation for Delta Dental.
Oh, okay, let's see.
I apologize for that.
Oh,
We always
sorry, we
have
should
the
have.
Presentation which had all the vendor presentations.
Oh, okay, later on in the book, is that true?
It should
In the book?
Where would that be?
I'll get you to the right place.
Yeah, it's probably in the, let me see. I don't know.
So the executive summary is
Sorry about that.
Yeah, I don't think it's there. All right, thank you.
They're missing the whole presentation? No, this,
What's the slide after this one?
oh, part of it's cut out. So I think that goes, it picks back up again in your book. It's missing the first part of the presentation, so your presentation in your book probably won't start until the utilization.
But where would that be?
No, it's this whole presentation.
Yeah, it's the whole presentation. Just make sure that we get it.
Sorry about that.
That's okay.
I apologize. Okay, so moving along, are you able to follow on a screen, or
Yeah, it's
do you
still kind of a little,
discombobulated? Sorry about
Yeah.
that. I guess it was a printing error. Are you able to see it on the screen, or? Oops. Oh, boy. Okay, so how do I go back? Let's see. Is that better?
Well, we keep this whole thing, but we can't see the small print, so just go through it, but make sure that we get the, and if we have any questions that we were able to see it, then I'm sure we'll get back to you.
Okay, I apologize for that. Oh, my goodness, I don't want that.
those pages for you all. We're unsure what occurred because we can see it in the PDF version of the book, just not the print. So we'll be getting that for you all.
You want to just
skip this and come back? Is she doing that now?
We could move on to the next vendor, and then I could come
Yeah,
back.
I think
We'll just
that's the
switch-
best.
We could just switch
Yes.
presentations up.
Yeah, because I'd hate for you to have to do it twice.
Okay, sorry about that.
So
Thank
the
you.
next one up is, there we go, Basic Life, AD&D, Voluntary Term Life, and Short-Term Disability Review, Mr. Bill Oakes from Oakes, Inc. And that would be number 10.
Click it. Okay. I think I'll just, yeah, because it's in this version, so. Okay. Hello, everyone. Thank you so much for having me here today. Bill Oakes with Oakes, Inc., and here to talk about your life and disability plan. The life plan's through Securian, and disability plans through Madison National Life, okay? And I'm going to just start out with something that we call at Oaks our municipal pool. And this will come into play in the next few slides or so. But Mohave County is part of our municipal pool. There's just public sector clients in there, cities, counties, and school districts. And there's roughly 800 public employers in the plan across the United States and about 240,000 lives. So it's a big group. And the reason this is important to Mohave County is because of the strength in numbers. So we can do things with your plan and the plan designs, and hopefully if there's ever a bad year in claims, we can do things that maybe other carriers wouldn't be able to do because, in essence, you have such a big plan. Does that make sense? So when those things come up on the slides, I'll point them out and show you the power of the pool. Okay. Okay, the first thing we're going to start is talking about the life insurance plan. And we're going to start with what we call the basic life or the employer-paid coverage. You buy $50,000 of life insurance for your employees, and hopefully not, but if something happened to them, their beneficiaries would receive $50,000. There's also what we call an accidental death benefit attached to that. So if that employee died accidentally, like in a car accident or whatnot, that would double to $100,000. But what we've done in our pool, and we make this standard across the country, and this would be, of course, just with cities and counties, not school districts, but we add a third benefit called our line of duty benefit. So hopefully not, but if one of your men or women in blue would pass on in the line of duty, that would be a triple payment to their beneficiaries, or a total of $150,000. Is there a question?
Just real quick, there is a push at the state for a ballot initiative that would make any in-line of duty deaths pay out $250,000. So if that were to pass, would you keep this, or would this be above and beyond that?
So would that benefit come from the state, not from
The state.
your plan? Yeah, so then that wouldn't have any bearing on that.
You would still continue that?
Right.
Okay.
So yeah, I'm not familiar with the state plan, but if that paid, this would still pay, okay? Okay, so anyways, that's your basic life plan. You also offer what we call either a supplemental or voluntary life plan. A lot of your employees might say, gosh, it's great. The county buys me $50,000. Maybe they're single and that's all they need. But then there's, again, an equal amount that say, well, you know, I have a spouse, we have some young kids at home that hopefully we'd like to send through college someday. We haven't paid off the house yet. So it's really good that you offer an additional benefit that they can do, and they pay for 100% on their through payroll deduction. And they can get anywhere from $10,000 more all the way up to $300,000 more on themselves. They can get up to $50,000 on their spouse. And then on the kids, they can get, they choose either $10,000 or $20,000, okay? So again, that's voluntary, what they pay for through payroll deduction, okay? Here's the rates on your plan. For your basic life, you pay 13 cents per thousand per employee per month. And then there's 3 cents for that AD&D coverage, and that does include that accidental death, so a total of 16 cents per thousand. And then below that, you see what we call age bandit rates, and that's a really good way to do it for a group employer, because the way it is every 5 years the rates do increase, but for your younger employees who need it the most because they still haven't paid for the house and the kids are still at home, the life insurance is the least expensive. And then as they age, they get to their 50s and 60s, and let's say they had $250,000, they might say, well, gosh, those premiums are getting pretty high, but the kids are gone, the house is paid for, so maybe let's cut it down to $100,000 or $50,000, and they can do that, okay? Okay, and I think all of you are pretty much aware that life insurance, if your employees want to add more, there's health questions. So if they have a chronic illness or disease or even an injury that may cause early death, the life insurance companies generally say, no, we're not going to let you increase your life insurance. We had a thing that we just went through, and we're going to look at your experience in a little bit, called the pandemic. And not on all our groups, but we're looking at a lot of our groups and saying, you know what, life insurance has really come to the forefront of benefits. People used to not think of it, but you might notice a lot more commercials on TV or radio advertising life insurance. But anyways, what we'd like to offer Mohave County and your employees is a special one-time open enrollment where all your employees can raise their life insurance amount by up to $100,000 without any health questions. I'm going to go through it in a little bit here, but again, what that means, if they have no coverage today and want to get an extra $100,000, they can go from 0 up to 100. Now, it's still in 10,000 increments, so if they just want to add 50, they can do that, okay? Normally, again, that would take health questions to increase your coverage. If they have 200,000, they can go add the 100 just because we can go all the way up to the plan max of 300. But if they were at 250, they could only add 50,000 because, again, the plan max would be the ceiling. So this is something the board will need to vote on. If you'd like to do it, you let the Gallagher team here know, and we'll work with your HR to get communication out to your employees so they know that this offer exists. But it's simply just checking the box, and effective July 1st, they'd have an extra $100,000, okay? So yes, there's a question.
Madam Chairman, I have a question. Is there an age limit for coverage for spouse and children, like, 70 years old?
So going back to that child life where they can get 10 or 20,000. So let's say the family chooses to have 20,000. Keep in mind it's one price, whether they have 1 or 5 kids. They're all covered for the $20,000, and it covers them up to age 26.
26.
Okay. So much
what about
like
the spouse?
Plan, yeah. Pardon me?
Spouse.
What about the spouse?
Is there an age limit for the spouse?
As long as the employee is active and paying the premium, the spouse, there is not a limit on that.
Okay, so there's no 70, 75 years old.
But again, remember the employee would have to be an active employee so that they probably would not be working at that age. However, when your employees do leave the county, they can take the coverage with them, whether they're 40 years old or whether they're 70 years old. And there's 2 different ways to do it. One is called portability, one's called conversion. And we work with your HR team to get that information to your employees too when they leave service. And when they do leave, they can take their employee coverage or their spouse coverage.
Okay, thank you.
Let's see, I'll find where I was here. Okay, so again, I think I finished with the one-time offer. If you're interested in that, you just let the Gallagher team know that, yes, let's move forward with that. And again, we'll then communicate that to all your employees and make sure that they know that if they want to, they can add up to $100,000 without health questions during the upcoming open enrollment. Okay. It's going to be tough to see this, and so I'm just going to speak to it. So we just went through a pandemic, and this is talking about your claims. So it's not unusual that you had a couple bad years. So the last year, January, from June 30th of 2021 to July 1st of 2022, you had a 139% loss ratio. So again, we paid out much more claims than we took in premium. Now, actually, the year before it, the first year of the pandemic, it wasn't as bad. It was 73% loss ratio, and that's actually a pretty good number in the life insurance business. But we realize that that's probably an anomaly. We're not going to see those numbers going forward. And you are in rate guarantee till June 30th of 2025. So we have time to see what happens over the next few years. And again, remember the power of the pool. You're in a really big group. So if you had a couple tough years in Arizona, maybe in Florida it was better or something like that to help out your plan here. Okay, any questions on life insurance before I go over to the disability plan?
Questions?
Okay, so I'm starting the disability plan. Now this plan, the county provides to your employees, so you're paying 100% of the premium. It's a pretty straightforward plan. It pays 60% of their weekly benefit her weekly salary not to exceed $2,200. So that pretty much covers all the salaries in Mohave County. So it'll pay 60% not to exceed $2,200 a week. It doesn't start until they've been out for 30 days, so there's a 30-day waiting period. And it will pay as long as their doctor says they're too sick or injured to go to work, or until 150 days goes over. So the benefit will last for 150 days, or until their doctor says to return to work. Okay. So that's how that plan works.
I have a question.
Go ahead, is there a question?
Yes. How is this, maybe it's a question for HR, how is this short-term disability insurance from them coordinated with this short-term disability insurance with ASRS?
So ASRS does not have short-term disability.
Okay.
They have the long-term disability. So after the 150 days of the short-term disability, then they can go on to the state's long-term. And both, if we know an employee is going to be out for a while, we give them the short-term and the long-term disability paperwork at the same time. So they only have to go to the doctor once.
Okay, all right. Thank you.
Yeah, that was a unique thing when we started doing business in Arizona. We sell long-term disability all over the country, but not here in the state of Arizona. So, okay. The rate for the short-term disability is 22.3 cents per $10 of weekly benefit. It's just strange how they do disability. It's not a monthly price, it's a weekly price, but that's the rate. And lastly, I'd like to go over how that plan is running. It's actually only a 26% loss ratio, so that's like super good in short-term disability world. But equally with the life insurance, how it made the last 2 years really tough, where there was a lot of claims in life insurance, there was very few claims, at least in our groups, for disability. And you might think, well, why is that? When you think about it, particularly short-term disability, what did not happen during the pandemic? And that was people did not have elective surgeries. They weren't going to the doctor or clinic because they didn't want to get sick. So that means knee surgeries and all that. So believe it or not, that for the disability payments or claims, that cut them way down. So this is a really good number. I don't know if we'll see that next year. It'll probably bounce back up to around the 70 or 80%, which is still not bad. But still, I just wanted to point it out that that's why it's unusually well. So any last questions for me before I turn it over to our next presenter?
Anyone? Any questions?
Yes.
Back to there's no health questions on the life insurance. Is there a waiting period after that?
No, that's a really good question. So let's say the board gives the okay to go ahead. We'll make sure that we'll help get the word out during the open enrollment period, which is probably going to be in late April or May. And then the employees can make their selection, and come July 1st, they'll have that extra $100,000. And so hopefully not, but if they died on July 2nd, it would pay out.
They would, even if something happened the next day?
Yeah, now there is this did happen during, it was another state. They have to be they have to come to work for at least one full day. They have to be active, so they would have to come into work on July 1st, and then it would pay out. Now, what happened in the case I'm talking about, the person signed up for this $100,000 open, but they were out on medical leave, and then they passed on, so the life insurance never kicked in. Does that make sense?
Ah, okay.
Okay. But as long as they're back to work one full day after the effective date, July 1st, then it would pay out. Okay.
Okay, thank you.
All right, any other questions?
Questions? Comments? Okay, thank you so much.
Thank you.
Next up,
Excuse me.
We have, we're going to go back to Delta.
When we were putting the books together, we made a mistake. If you look at the Delta Dental presentation, if you go to the presentation right before it, section 8, the very back part of it has the Delta Dental presentation. That just needs to be moved.
Okay, let's see. Here we go. Got it? So 213. Yeah, there it is. All right. Mystery solved.
We should take that out.
Thank you,
Put
Lost and
it-
Found
yeah, if you want to
Department.
take it out and put it into the right.
So let's see, I don't know what kind of word you would get, Ken, but a dentist of the Year award is just a little plaque. Get it? Little humor there. But now I can't find my presentation, so bear with me. Now that we located it. Okay, so does everybody see the executive summary high plan? Thank goodness, okay. At least we identified the issue. Okay, so the executive summary for the high plan, as I mentioned before, 40% of your claims were focused in preventive and diagnostic, which is really good. I do see that your average claim payment for the high plan did go down, and again, that's it's attributed to two things. One is your preventive services are going so well. Perhaps people don't need to have a lot of work done. The other is even though your utilization is going up, claims per member, your cost is going down, and those are the PPO savings and the savings that you're seeing coming from going to a contracted provider. Let's see. I'm trying to get into bear with me from beginning, no, from current. Okay, sorry, it's hard for me to read and I forgot my readers. They're lost too. So your average claim per member was 1.77. Last year it was 1.53, and then per subscriber was 4.23, up from last year 3.64. Your member age is pretty current with Delta. It shows a little bit higher, but that's probably because you have a little bit of an older population, and this kind of excludes some of the plans that recover retirees. So it's not really a great comparison, but it kind of gives you a snapshot. The percentage of procedures performed by Delta dental dentists, say that 5 times fast, was 96.2%. And then your savings and your cost management savings, some of the toolkits that we'll go over a little bit later, averaged about 40.15%. Turnover was 19%, but that does include people that may have moved from one plan to the other during open enrollment and so forth. So bottom line of your current utilization is you have about 1,342 members. The percentage of members with claims was 43% compared to the last year, which was a little bit higher. So I'm not quite sure what's going on there. Sure.
Do we have the same amount of providers, and specifically in the Havasu area, have we lost providers?
No, you have not lost
this?
providers, no.
Okay.
Everything's the same. We, our Premier network, which is the exclusive network, I don't want to say it's a narrow network, but it's, it has an agreement with the dentist that they accept no other insurance coverage. So they're exclusive to the Delta Dental family. And that network is closed. We haven't added anybody or taken anybody off with the exception of a death, that happens here or there. Other than that, we're constantly recruiting and adding PPO providers.
Okay, so if somebody in Havasu is saying their doctor no longer takes Delta Dental, that would be incorrect?
Well, that would be something we would want to look into because I have not been made aware of a particular dentist leaving in Lake Havasu. So we can certainly take a look at that.
Thanks.
Other questions?
Okay. Okay, on the low plan, your preventive and diagnostic services are up even more, 50%, which is great. Our book of business typically sits around 39 to 40%, so that's a really nice uptick. And then again, I think a lot of it attributes to the wellness program that is offered, and people can get their clean exams and x-rays done. We send a report. on a quarterly basis, a person becomes eligible for the electric toothbrush, which there's a drawing and it happens every quarter. So we then send them out their Delta Dental toothbrush, which is really, it's a very nice gift. Your average claim payment on the low plan did go down a little bit from 137 to 133, and your utilization stayed pretty much the same. If you look at it, 1.2 claims per member and 2.22 per subscriber stayed fairly the same. Your average claims filed by a Delta dental dentist was 97.1%. Your savings in this particular low plan was 37.99%, and then your eligibility turnover was 31.5. And then your members covered in claim counts was 486 members, which represented about 36.9% of the population in the low plan, compared to last year, which was 339 with a 52.7. So again, that could be a result in people going to the dentist but having multiple claims rather than more people going to the dentist and having the same amount of claims. That's kind of how the measurement goes. Your claims by coverage category, can everybody see those pages in your booklet? Okay, so we're on the right track. So basically, I pretty much pay attention to the pie chart below. It's a little more detailed information up above, but at least you can kind of get by the pie chart a pretty good picture of what's going on. Like I said, your preventive services, your diagnostic services, and all other radiographics are all included in these little breakouts. I did not see any significant change or uptick. It looks like your implants went, let's see, they went down a little bit. So that could also bring down the average cost of the claim. So if there are less people getting an implant, I know a couple years we relaxed some of the implant language and made it a little bit easier for those people to get an implant. And then on the claims by coverage category low plan, same thing. Your little pie chart represents how your claims are broken out. That gives you a good idea of where your dollars are being spent. And then the next slide over is the claims by member status. I thought this would be kind of a good illustration of how we look at your claims. I see that, oops, how did I go there? Okay, let me go back. I'm pushing buttons that I shouldn't be pushing. So right here on your claims, average current 12 months, there was a little bit, on the high plan, I see that the prior month was a little, the current month, I apologize, was blocked off. It was like 44%. So your subscriber count on the low plan was sitting at 49%, non-spouse was 25%, and then spouse was about 26%. So you do see that your subscribers are, your actually employees are using the plan, and so are their families, but you just have a higher count in the subscriber section of it, which is good. We like to see that because that means that a lot of the employees are using the plan, not just their spouses and dependents. And then your cost management savings on the high plan for the next slide. I know these numbers are a little bit small, they're a little hard to read. So just kind of going over it, we break down your average savings. If you look at that first line, the Delta Dental PPO savings, and then the Delta Dental Premier Network savings, the non-participating dentist savings, which isn't really all that great. Consultant review, non-billable procedures, those are basically a result of bundling or unbundling claims. Sometimes a dentist will send in, we noticed during COVID, a lot of the dental offices were charging for PPE, so it was like $25 to walk in the door or and so forth. So rather than the Delta Dental Family Association, covered by 39 states, decided to select this as a non-covered service and a non-billable service. So they're not able to bill it to the insurance company, to the members, or to the group who pays their own claims, to the self-funded groups. So we thought that rather than adding another code and trying to get that covered, it would save a lot of money. We did offer a couple years ago a PPE reimbursement. What we did is we offered all of our participating dentists to send us the number of claims that they would have presented to us in the Delta Dental family, and we gave them a set dollar amount, and we averaged it out, and then we did offer to help subsidize for some of those costs. And we have now kind of discontinued doing that service. And if you think about when you do go into the dental office pre-COVID or post-COVID, the dentists wear masks anyways, and they wear PPE protection. So we just looked at it as, you know, several years ago, everyone was charging for oral hygiene instruction, or they were charging for sanitation and different things that should be included in your overall cost for that visit. They don't charge you a separate charge for Novocaine when they're going to give you a filling, so why would they charge us for PPE? So that's kind of the reasoning behind our philosophy for it. So your overall net savings way down at the bottom represented basically, once you take into consideration your per member savings, your claim adjustment savings, any type of other savings that would have came across the plan, shows the bottom line over here, gosh, over 66%, I believe it was, on the high plan. And then you're moving to the next slide, your claims by member status. Oh, should I go forward? Sorry, I went the wrong way. So same thing with your cost management savings on the low plan. The top dollar amounts are, this is the amount of claims that were submitted to Delta Dental, and then the amount of claims that were actually paid out. And again, you can see the savings that you're getting from the PPO providers, and then the savings that you're receiving from the premier providers. The non-billable savings, again, is the kind of like the upcoding non-covered services that they can't bill to you, to the plan, to the subscriber, and no balance billing as well. And for your low plan, your overall net savings, again, was over 69%. I see that right. This slide is just basically the definition page of all those line items that were in there. So you are welcome to reference that to go back to look at a particular line item if you want to see what that clearly describes. And again, in the middle column, there is the non-billable procedures, which is kind of like one of our most famous, popular, I should say, savings amongst the people and the companies that we insure, because again, we have a little bit more stringent non-billable. You're not charging the patient for 20 x-rays when you could just do a full mouth, or you're not charging them for Novocaine or oral rinse when you don't need to be doing that. It's part of your overall treatment. And then this is where we kind of got lost in the beginning of the presentation. So this is the dentist selection patterns reports. Basically, on your high plan, I think that goes back to the beginning where we noticed that you guys didn't have the same.
Yes, it's tab.
Okay, thank you, Hildy. And so what we like to share with you is your overall savings, and as you can see, we list you the amount of claims, excuse me, the net plan and pay sum of the savings. So for your PPO network, there were over 2,400 claims submitted. For your Premier network, there was over 200 claims submitted. And for the Premier network, by the way, those are exclusive providers. Say they only accept Delta Dental coverage, no other insurance coverage. And if you are with another carrier, those would be considered completely out of network. So you would see balance billing, and you would not not be getting that savings. And or if you decided to elect just a straight PPO plan, we do sell that type of product, but for this particular area and being in the rural areas, we find it best that you utilize both the PPO and the PPO Plus Premier Network because it just gives you more access points. For the low plan, the same thing again. If you look at that, even though there was only 38 claims for the Premier Network, you did experience quite a nice savings from those. And then the non-participating providers, I should have mentioned in the previous slide as well, those are just non-contracted providers, or some people choose to go out of country. I'm not exactly sure why. A lot of people do, we find in Arizona, because it seems like a border town, that we do see people going to Mexico a lot, or California, San Luis side, and so forth, because they feel that their dental work is less expensive. So we do find that there are some people that do go completely out of network. And then again, some of the dentists that are non-participating that are in Arizona or in the United States for that matter, some of them just don't accept any insurance, period. So that's why you'll always see those showing up on your report. And then going into the customer service results, we have to carry our trademark name and be part of the Delta Dental Plan Association. We have to abide by performance guarantees, just as if we do for our clients. We're expected to do the same thing to keep our trademark and keep everything the same. So all the Delta Dental companies do get measured, and we are subject to fines and so forth. So we take really good care of how we manage our staff. We have claims people that know how to answer phones, and we have phone people that know how to process claims. They're cross-trained. We also have people or dental offices that call in, and maybe there's something missing from the claim, rather than waiting for them to send it back in and, wasting a lot more paper and a lot of people's time. They can take the information over the phone, and that's what we refer to as one and done. We go ahead and process the claim right there, and then most of the dentists are set up for EFT. So basically, their claims come in through a clearinghouse, they're processed. Our drop to pay rate means it requires no manual intervention, happens very quickly, and so they're paid right away. So the money goes right back into their account. So it's kind of an incentive for the dentist to sign up for it, and they get their money right away. So your average customer service is within 19 seconds. These are some of the performance guarantees that we're required to follow, and we are happy to report that 98.9% of those inquiries were done on the first contact by a benefit advisor. So those are the one and done claims, and then they're answering the phone quickly. 99.9% of those claims, if there's a written inquiry, they're resolved within 5 calendar days. A lot of people that we insure work the same hours that we're open, so they don't always have time to call in to our member services, so they'll send us an email. They can contact us anytime, and that's 24/7, and then they respond to them right away. Your claims processing, the average claim turnaround time is 3 calendar days, so we're pleased about that. Again, we process claims for 1 week at a time. We batch them, and then all the payments are mailed out, and then we kind of bill each one of our clients on a weekly or monthly basis. Your processing accuracy, we randomly select a number of claims to make sure that your particular group is set up, the benefits are correct, you're not paying something that's not covered, you're not paying something in the wrong category. For example, a crown, you're not paying at 80%, you're paying at 50%. So we continuously randomly select a number of claims for financial accuracy, which is 99.9%, and then the claims accuracy, the number of total claims process is 95.9. Your enrollment processing, again, is average 3 days. So basically, we receive electronic eligibility files, and those go into a queue, and they're loaded into our system, and they run through a test environment to make sure that there are no errors on the files, because we would hate for everything else to bomb out. So if we get a file and sometimes it shows there's this enormous amount of terms, we'll stop the file and then contact the client to say, is there possibly something wrong with your file, to research it before we load it into the system, which causes less errors and less disruption, less phone calls for everybody. The average turnaround time to issue an ID card is about 7 days, and it's like 99% accuracy. We do get a weekly report that shows, like, if somebody got entered into the system and they were missing an address or something, we go back and research that so we can send them the correct information to the correct address. And that's my brief summary. Does anybody have any questions for me? Go ahead.
I have a question for you in terms of double coverage. If employee and spouse are both employees of the county, can each one cover each other so that they have 100% coverage for some of the services? Because some of the services, they only pay 50%, even on the high side. So if you have a husband working in public works and a wife working in finance, can they cover each other so they have a double coverage?
I believe that's not allowed.
Okay.
Ken. So we do coordination of benefits. So if you worked for the county and one of your spouses worked for the hospital, for example, then we would be able to coordinate benefits because they're different employer group contracts.
But not in the county.
No, not in the county. And just as a personal, my wife has dental through the school district.
Yeah.
And so the doctor coordinates it. And
Yes.
sometimes you get a bigger discount on your copay,
Yeah.
but it's not 100% on most things.
Okay, so
And I'm not sure, sometimes we see with some employer groups, if there's not dual coverage, but why are you paying coverage twice? So sometimes it's easier for one of the employees to elect family coverage. It's less expensive than for each one to elect single coverage and then one carry the dependents.
Okay.
So sometimes you'll see some savings introduced that way, so at least it gives them some type of benefit. But we typically don't allow it in employer group contracts, so you work for the same employer. And we have a lot of trusts, unfortunately, that kind of, that's what they elect to do. So it seems, it doesn't seem to work always in their favor, because you could have two different school districts that are in this one trust, and then sometimes it won't coordinate the benefits there either. But we try to make sure that we work that out so everybody gets the coverage that they need.
okay, thank you.
You're welcome.
Quick question. Other than the PPE scam, and you haven't talked about this in any of the providers, have costs gone up because of inflation?
So provider costs have gone up, but we do not update our national provider file fee schedule. It's not done on an annual basis, and a contracted provider can submit their fee, any fee that they want to us, but they have an agreement with Delta Dental to stay within, I want to call it usual and customary, approximately the 90th percentile. So if, and it could be the 90th percentile from 2 years ago, hard to say, but some dentists might charge $100 for a cleaning where another dentist will charge $80, and then a dentist in another neighborhood will charge $60, but the average fee averages out of all the submitted fees together. So even though the cost of living is going up, the cost of dentistry is going up, they're still bounded by contract to offer those discounts.
Thank you. Any other questions?
All right, thank you.
Thank you very much. Now we go on to the review of actuarial renewal report and benefit change options, Mr. Marshall. And that would be, I would assume, number 11? Tab 11.
So, Madam Chair, with your permission, I'm going to tee this up. I'm not an actuary, but I did sleep in a Holiday Inn Express last night, so.
I didn't hear one word you just said.
It was probably good. It was a bad joke. So Chris is going to go through the numbers. He's going to go through the actuarial piece. I just got to put a caveat in here. We have 2 executive sessions in the meeting. One is to cover PBM and one is to cover dental and vision, okay? And we're doing that executive session under the advice of counsel for contract subject to negotiation section. So I've asked him to be specifically opaque on those to respect the items that are going to be discussed in each section.
And is the E session, because it's not on the
The
agenda.
active meeting, and the meeting after lunch.
After lunch,
Yeah,
okay.
there are 2 of those are posted. So he's going to, when he comes to PBM, what his assumptions were, when he comes to dental vision, going to be opaque because they're going to be subject to the executive session requirements.
Okay.
Okay?
Mr. Cellophane, come on up.
Yeah, I'm not sure where it is on here. Oh, it's just further down. Okay.
I just saw you.
Oh, there it is, the arrows.
There you are, of course.
Thanks. Hey. Thank you all. I think it's the first time I've been here since COVID, so it's been nice to be back in person again and see everyone. So I'm going to take you through the rate development for the plan year beginning January 2023. So just an overall summary of our methodology. We, of course, every year assume that prices are going to increase due to trend, which is the catch-all term for price increases, utilization increases, new technology. And the factors we used were an annual rate of 7.1% for medical and prescription drugs combined, and then 4.5% for dental. Medical and drug were priced separately from dental since the plans are separate. Unlike past years, we did not feel that there was any adjustments needed to the data to take into account the impact of COVID-19. In 2020, any data from there, that definitely was because of the lockdown and people not getting elective services and so on. But the data since then, we have not really seen a need to adjust. We did make adjustments for a few things on medical. So as Aaron mentioned, we will discuss more in executive session with what's going on with prescription drugs, but there is some price decreases that with Navitas that we did include in what I'm about to show you. We also included going to complete mental health parity, so that's been included in here. And then we did notice that in the second half of last year, there was a sharp increase in your prescription drug claim cost. Not all of it was due to the hemophilia drug that was discussed earlier, and we did note that it's in there, but we did note that it's not going to continue. However, there were several specialty medications that were, while not as expensive, still pricey, and they were new in the second half. We did some research to see what would be the likely duration for those, and a lot of those were going to continue into the next plan year, so we factored that in to make sure that that would be accounted for. And we used data from calendar year 2021 and 2022. So just at a high level, the recommended rate increase for medical is 5.4%. That is below trend. That is definitely an increase that is much smaller than what I'm seeing at large for most of my other book of business. So that's definitely good. And also good is on dental, we have a rate pass is what we're recommending again. So no increase. On the medical, there's a lot of numbers on the chart, but what we're showing in the development of the medical prescription drug rates is we have 2 years of data and we're going to average them together just to help smooth out any year-to-year fluctuation that there might be in the claims, just to give it more stability from year to year. So the first column is the 2021 data from calendar year, and the second is 2022. And we have the claims and enrollment, and we get to a per capita. Then there were a couple of minor plan changes over the years, so we adjust for that to get those claims on the same basis. Then we have the aforementioned trend to bring it up to the current, or to the projected year. And then we have the adjustments that I mentioned before. So the first is mental health parity. And as you can see, it's very minor in cost. Then we have the specialty medication load that we had, and that's definitely not minor. That's why we wanted to include it in here, to make sure that you were not going to be underfunded for that at that time period. And then we have the negotiations with Navitas included, which were a decrease, which almost offset the increase due to the increased specialty drugs. And the negotiations with Navitas, that includes actual prices of prescription drugs in addition to the rebates. So anything with admin or anything like that, that's not included here. This is just pure claims, what I'm showing. So after the two columns then are averaged, they each get 50% weight, and then you can see it's $972 almost, and that represents an almost $50 increase over the current rates of $921 and change. So that's how we get to the 5.4% increase. We do have a minimum and a maximum as well, where if you wanted to just isolate and take 1 year of claims, so 2021 or 2022, one's going to be higher than the other. But then averaged together, that's the 5.4. Any questions on the medical?
Any questions? I have, so mental health parity, what exactly does that mean?
Basically, mental health has to be covered the same as any other outpatient procedure. There can't be limits, lifetime limits or limits on the number of visits in a year. And it's just making sure you're in compliance with that.
We've talked about this in the past, haven't we, Erin? You know, I mean, honestly, in the world of treatment, it can go on forever. I mean, it could 3, now they're going up to 6 months, and that gets pretty expensive.
And Madam Chair, this will break your heart more than mine, but the feds have basically eliminated the window or the option now. So that
okay, so it's just a mandate.
Well, you're correct. We did this conversation, I think it was 2 years ago, and the issue was relapse and how many times, for example, you can go through rehab. So we put a limit on of 3 because we had the mental health opt-out. That's been eliminated. So we just had it built in to the numbers. And you're correct. The length of stay, you still have medical necessity, you still have standard of care, right? And we do have a case management firm to do that. But you're essentially correct. I mean, it's really what it's going to be a tough one.
And it's kind of arbitrary. I mean, it's not really a medical thing. I mean, the people making decisions, but you know, I find it unfortunate now that it's mandated, and I think unfortunately, some of it should be a bit, you know, discretionary. But
my main point is, frankly, there are some breaks on it. Also in network, right? So we've got the in network things that we can put some controls on. The one we're not going to get away with, and we all know it with the opioid crisis and all of these things, is going to be that relapse. I mean, that high relapse rate. I think it's above 80%. So, but we are going to deal with that now. So that this one's not an option anymore. Okay.
So the next slide shows the development of the dental rates, and it's done in the exact same manner, except that haven't made any adjustments, and the trend rate is a little lower. It's 4.5%. But as has been the case is in prior years, there is the projections are coming in under what the current funding rates are, so we're recommending a rate pass. So. And this is with Delta Dental in place and everything as today going forward. So, any questions on the dental rates?
Questions?
Okay.
On the packet for the dental rates,
yes.
Below it says does not include impact of changing to emeritus. What does it mean?
We'll get into that in the executive session.
It's
the looking at the dental and vision. So.
Okay, thank you.
Mm-hmm. The next slide is just what the claim funding rates would be with our recommendation for the medical and dental increases. We have the current rates as the first column of numbers. Then I mentioned before, if you isolate on one of the years or the other, you get the higher, the low end, the minimum, the maximum increase. The average is what we're recommending, and that's the one shaded in gray in the middle. So this is what the funding rates would increase by with our recommendation.
And just before everybody sings too much on those numbers, these are only the funding. They don't, when we get into the budget conversation, we'll include what we assume for stop loss, the price of the wellness portal, all those other HR, those types of things.
And then on the last slide, I have you may have heard President Biden announced that effective May 11th, there will be an end to the emergency for COVID-19. So that brings about some potential changes that you may want to look at for July 1st. There is, we talked about earlier about the COVID vaccine, so those would now have to start to be covered by the plan, and those are going to be, now that it's the private sector paying for it, the companies suddenly have decided to charge a little more. So that's included, or that's something to consider. Another thing is if there is going to be coverage out of network for vaccines. Previously there was, because anywhere you went, it was covered. You might, every other plan, or I think, would cover it in network. It's just something to consider if somebody goes out of network, if that wants to be covered or not. There was also the testing. So if you got your home kit, you could get something straight from the government sent to your house, or you could go out and buy one. And if you bought one, that was covered for a while, so you can decide whether or not to cover that. We've seen usage of the kits plummet recently, especially over the last winter. So I would not anticipate that being a major cost, but it depends on what you want to do. So then there was also an extension of the guidelines for the COBRA elections and payments, and there were some things with your high cost plan where you could cover things first dollar because of the emergency. So you could do telehealth, and you could do there's something else, and it just popped out of my head. But there was, I think that's been extended, right, to the end.
We can incorporate both telemedicine and telehealth.
Right. Yeah. Right, and I believe that was through the end of the 2024 plan year. So, and that is something that we priced out as a plan change, which we'll go into in the e-session. So, any questions on the COVID emergency ending?
Anyone?
Okay. Thank you.
All righty. Now we have Mr. Collins come up. And that would be tab 12.
We'll actually be done pretty early, Madam Chair.
Okay.
Okay, so in this case, as Madam Chair, as I mentioned earlier, we're not going to come in with recommendations. We're actually going to, on the two items that involve the benefits, when we get to the regular session, we're going to suggest whether you adjourn or what. We'll come back on those, because as we get into e-session, you'll see the items that are subject to negotiation. What I'd like to do is show you the actual rates that are in effect today, because when we talk about the medical specifically, have you heard
this in our packet?
Okay, can you see it on your screen?
Well, again, we have that problem.
Okay.
This wasn't part of the packet. Oh, that's not part of the packet? Okay. All right, I think we can figure it out, though. No.
How's that?
No, worse.
Go back the other way?
Go back the other way.
I think when it has the tiles on the side is when they can see it.
You see it now?
I think we can make this
You know,
work.
and I'll tell you what I'll do, Madam Chair. I can actually suspend this. I'll bring it back after lunch. We'll print them.
You
And we'll
sure?
bring them, that way
Okay.
everybody's got them. So in essence, what I'm going to focus on, what we're really looking at with Ken and Leanne, when we do the conversation, we're looking at a fairly significant restructuring of the plan, with the concept being they're having trouble recruiting, they know where it's at. But really what's going to drive that conversation is the medical. Okay, because we know, as I mentioned before, we got the Delta, that's what this was supposed to do, and we'll show it to you when you print it out. I think we're kind of at a tipping point on the rates in terms of what we've done before, was we were trying to draw down that surplus, excess surplus, that's a weird term. I think we've accomplished that, or we're very close, but we are kind of in that place now where I think we're undershooting on the rates, okay? So what we'll do is we're going to talk about, with Chris, we'll be talking about later on how that accumulates. Okay, so if we're behind now, just for argument's sake, say 15, 17% versus his target funding, his target 4.5% increase assumes you're fully funding to his current number, and that's not the case. Okay, so if you look, Chris and Meritain were using a 7 to 8% inflation rate. Okay, and if we're behind that, there's a question of how far behind it are we net? And that's what we're going to work on with your finance department. So we're going to clarify what the real losses are. We'll get with Chris, and we're going to kind of refine this number down to close that. But my concern is we've been for about 4 or 5 years, right? We've grown the delta between the actuarial rate and the actual funding rate. And I am concerned that we're at a tipping point. We're going to get behind the curve. And that's kind of the nightmare scenario, because we do have an accelerating rate of inflation, which we're all seeing. And in fact, it is getting into the hospital negotiations, which represent about half of your total spend. So this is not a Chicken Little. This is a common sense that says, hey guys, look, we got away with it. We did what you intended to do. And frankly, I think it was a very wise use of public resources, what happened, but don't get too confident in it. And let's have a conversation about how we can get the rate closer back into line, right? So that if the inflation continues, next year's not the crazy time. Right, I think we just need to be really diligent and understand what we're doing on that funding decision. That is going to flow through into whether or not we can pull off with the dental and vision. Really, it's the vision. We're targeting the vision. Whether or not we can pull that off to help you become more competitive. Okay, so they are all interconnected. And when we get into the conversation in the E-session today on the PBM, what you're going to see is they're all connected. We've made assumptions using the least favorable PBM offering. So how that whole thing comes out, it all kind of fits together. And I know that's a little bit complex, but we're trying to get the vision thing fixed. We're trying to make sure that we don't slide so far behind we get the trust in trouble, right? Because what the goal is not to disrupt county operations by, kind of running holy water through the water fountains and hoping that cures everybody of all their illnesses, type thing. Okay, so what I'd like to do, Madam Chair, is I'm good. We'll print copies of this. When we come back into the regular session, I'll talk about that delta, and when we go into executive session, we'll talk about the negotiations we want to do on the contract and how that fits in.
Okay, does anyone have any questions for Erin? So we're ready for the break?
We're ready, Madam Chair.
Okay, thanks so much, and thanks to everybody. It's really interesting, thank you. And we're going to go have lunch, and it's, I believe, upstairs in that room near HR. And we'll be back, it's right now, pretty much on time, about 11:45. So you want to be 45 minutes or an hour?
Actually, you can't start your meeting till 1 o'clock.
Oh, okay, all right, because it's posted, right? Okay, 1 o'clock we'll be back here. Come a little before so we can start right on time.
Chair Angus?
The lunch is in HR.
Oh, yeah. And then they drive around. No, we need it. Okay, it's 1 o'clock, guys.
We're not like the legislature. But I was down legislature, I'm used to, if it's 1 o'clock, it's 1 o'clock, right? They were like, you know, walking around the floor. I'm like, wait a second, it said, no.
And you want to be part of it?
Desperately. We didn't get to talk, but I do want to. Okey-dokey, we ready to roll?
Ready to roll.
Okay. So let's see, are we going, I'm calling this meeting back to order. Is that good, lawyer?
You're actually opening this meeting.
Huh?
This is a new meeting.
It's our opening.
Oh, I'm opening a new meeting of the MCEBT Trust. And we're going to go into e-session now? Or do you want to say
So,
something?
Madam Chair, I think most of the items, this is going to be pretty quick. I think just for logic, I think if we do the e-session on the 2 items that are in e-session, we can come back and go through the remaining items. I
Okay.
think it'll be more logical.
So let's do it now, you're saying? Just
Yes.
like I asked. Okay. So I need a motion to go into executive session?
So move.
Second.
Yes.
I would like to have the roll call first. I'm sorry.
We didn't do a roll
Because
call?
this is about the discussion and possible action. We need to have a quorum.
Oh, okay. Okay, that makes sense. Okay. I'll wait for our clerk to do the roll call.
We can do one. Member Elters?
Present.
Member Jacks?
President?
Member Duranzo?
Present.
Member Angus?
Here.
Member Bancroft?
Present?
Member Tennell? Here. All present.
Okay.
And should we go to the call to public first, then we go to executive?
Okay, I will make a call to the public. Anyone wishing to speak? Anyone? Hearing none, I close the call to public. Now? Now can I ask, okay, I need a motion to adjourn into executive session.
So move.
Second.
All in favor?
Aye.
Opposed? Motion carries. We are in E-session. Scram.
Yeah, he can stay.
Madam Chair, we're getting a document loaded. We're getting a document. Okay, so this is in your trust meeting packet, Madam Chair. Not on the screen. It's under tab 17.
17.
Well, good afternoon, board members. As Chairman Angus said, my name is Luke Mornian. I'm the Chief Financial Officer for the county. Took over for Coral when she retired a few months ago. And so I will do my best to walk you through this. We'll just start off there on page 8. You have a couple of images there, but the top one, through December 31st of 2022, at that date, the trust fund balance was about $10.9 million. And as of today, it's still sitting right around $10.9 million. The balance at the end of fiscal 22, so June 30th, 2022, was about $8.6 million. On the next slide, I'll direct your attention to the graphic in the bottom left-hand. There you can see a 3-year history. And again, these are fiscal year basis, so this is going through June 30th, 2022 on the right-hand column there, but you can see we've had a steady increase in the amount of claims individually, and then also the overall amount that includes the administrative costs. For last fiscal year, claims were about 12 million, which was roughly 750,000 more than fiscal 21. And when you include claims and administrative costs in there, we had an increase of roughly $1 million, totaling $14.3 million. If we look at calendar year, and so this would be on the bottom left or right hand side, excuse me, you can see there we split it up in the first half and second half of each calendar year. So calendar 22 in its entirety was about 12.5 million, and that's just claims. I will stop right there and ask if anyone has any questions so far.
Any questions? Sam?
No question.
Okay.
You have a question? The chart that you presented, the cash flow, is that the current cash balance as of December 22? You mentioned 10.9 million?
Yes, so as of December 31st, 22, the cash balance was approximately 10.9 million. That's correct.
Well, that's the cash balance. And then what you mentioned earlier, as of the claims paid in December 2020 is 12 million.
That's correct. Okay. Moving into what we have as a proposed budget so far. Again, on the revenue side, our actual numbers for fiscal 23 through December 31st, about 7.4 million, and we are, sorry, and this is not in your packet. We did not include the projected numbers. Give me just a second here. So the projection out to the end of fiscal 23 is about 14 million in revenue, and that's compared to the budgeted amount of about 13.6. On the expense side, our budget for fiscal 23 was right around 15 million, and we're projecting expenses of about 13.8. And so that puts us on the upside about $200,000. And so our ending fund balance that we are projecting is still right around 10.9 million. So we would head into fiscal 24 with a $10.9 million fund balance, but we were projecting we will end fiscal 24 at about 9.5. So that's the $1.5 million shortfall that's been discussed. And that is all I have for you. If you have any questions, I'd be happy to try and answer them.
So what is the, what was the number that the actuary said that we should have in the fund balance? Because it's very similar to years gone by.
Ballpark measure 7.5, 7.
Right, so we're still in that range. Yeah.
You see the trajectory, we want to make sure that we don't.
No, I understand that. I understand that. Okay. Just wanted to make sure, because it's very similar. We don't really, at least since I've been here, we haven't strayed too much from that 10.5 million, 9, 10, even when we took the $1.5 million out. My fear is if we were that much short, then I'm going to hear, about that $1.5 million that I advocated that we take for it, because you guys have always said we had too much in our reserves. So, okay.
Madam Chair.
Yes.
A follow-up with Luke, if I can. Luke, on the revenue side.
Yes.
I thought I heard you say the projections for FY23 were 13.5, or the revised budget was 13.5, and the projections are 14. So we're taking in $500,000 more than what was budgeted.
That's correct. So the revised 23 budget was about 13.6. We're projecting about 14 million. And the real difference there, when I look at that compared to last year, is that there was a Navitus rebate of about $200,000 in fiscal 23. The rebate we received in fiscal 22 was just a little over 100,000. And then we also have received about $200,000 worth of stop loss payments in the current fiscal year. Didn't see those last year. We've also received a pharmacy rebate that was about $50,000 more than prior year.
Okay, so that was the revenue side. Now, on the expense side, I think if I heard you correctly, the projection for FY23 was below what we budgeted in the way of expense for FY23. Did I hear you correctly?
That is correct. Our budget was about 15 million and the projection is 13.8.
So can one safely assume that the delta between those two, the 400 in the revenue side, which is in the black, and then the overperformance or under expenses on the expense side, which is 1 or 1.2 million. So overall, we're talking about $1.5 million in the right direction, not the wrong direction, right?
Unless there's there must be a formula incorrect on here, because yes, that's what I would get to.
So intuitively, that is, I mean, if we were to wish for an outcome, that would be the kind of outcome that we would wish for. Our revenue would come in more than what we budgeted for, and our expenses would be under budget. So that should help us. Again, if we need to go back and, in light of this discussion, revisit that, we can. But that's based on what I heard you say. I find that good.
All right, Susie. Just to clarify, what you're presenting right now is a budget, because of the 2013, which ends June 30th.
2023.
Yes, we're projecting out to the,
What you're saying is that there is a little bit more money when you calculate your revenues versus expenditure for the current budget that you have. You don't have the projected budget yet for the next year of which our programs will be under.
we have a requested budget, but it does not include any changes that the board would vote on today. And there's an awful lot of uncertainty, as has been discussed, just with the inflationary environment, whether the pharmaceutical rebates will continue at the magnitude that we've been seeing them. The claims also obviously fluctuate quite a bit year over year. So there's a lot of uncertainty in there when it comes to looking ahead to next year's budget.
Basically, we cannot bank on the ending of budget 2023 to float whatever we're talking about right now for the next year's budget for the trust because of the uncertainties you were talking about.
That would be correct. And I would just say as a matter of conservatism, knowing that we have significant uncertainty, that the more we can do to, even though the fund balance is higher than the actuarial recommended minimum reserve, I would still recommend that we don't try and eat away all of that all at once.
Any other questions?
Madam Chair, I have one for Aaron, if I may. In light of what we're discussing with the budget and the upcoming meeting in 2 or 2.5 weeks, how much latitude or how much flexibility will we have in saying, exploring some scenarios related to premiums? Meaning, what if we were to do an X or a Y? Is it 2? Is it 2.5? Is it 3? And give you enough time to work with us and give us answers in order to still meet the deadline of when we go to implementation?
I think quite a bit, Sam. I think quite a bit. 'Cause we're used to doing those what-if scenarios quite a bit. And I think what we're going to do is the big number will be what happens with the PBM, right? And if that's actuarially significant. And then just finalizing the numbers in the dental. And then we'll kind of back into it, but we'll be talking with you guys in particular. We're trying to figure out where is that fund balance today, right, to get numbers. The cautionary note for both, when you start talking about, well, if the budget comes in under, those are one-time revenues. What we're doing in building the rates is building structural rate adequacy. So that's a going forward, right? So the money, if we do get a surplus, if you get a year just like your surplus, that's great. But it doesn't make the rate adequate. And that's where we got to get us to where that rate is adequate to carry the claims on a going forward basis. That's what we're going to try and do. Okay.
Thank you.
I keep reminding me to use this. I'm getting texts that they can't hear me, so it's on me. All right, next.
Madam Chair, I believe you're on the reinsurance renewal process?
1 second, I'm a little discombobulated here.
Sorry.
Did that, the reinsurance, now we're on the reinsurance?
The item is agenda was approval of the financials through December 31st. So we need a motion.
Okay, so I need a motion to approve the financials as shown.
Madam Chairman, are those the financials that look presented? Is that the one we're approving?
Yeah, of what, up till now?
To December 31st of 2020.
Right. Yeah.
It's item 2.
It's basically just accepting it. Okay, so I need a motion.
Make a motion to approve the financials through December 31st, 2022.
Second.
All in favor?
Aye.
Opposed? Motion carries. Okay, now we are on to Discussion, consideration, and possible action regarding reinsurance renewal process. Mr. Collins.
Madam Chair, this is an annual item, just to clarify what it is. So we're going to start the renewal process on the reinsurance. It's a very quick process at the end. There's kind of a point where you go grab it. So what the Board of Trustees has done previously, for as long as I can remember, is authorizes Ken, we'll work with him, we get the best number, he'll sign it, and then come back and you'll retroactively approve it. It gives you a chance to ask any questions on it. So
Okay, so what would the motion be?
the suggested motion is move to approve Gallagher to work with Ken Cunningham, Human Resources Director, to negotiate and bind the reinsurance renewal effective July 1, 2023.
Okay.
Make that motion.
You make that motion?
Second.
Motion second, all in favor?
Aye.
Opposed, motion carries. Thank you. Discussion, consideration of, and possible action regarding prescription benefit manager, PBM request for proposal.
Would you like a suggested motion, Madam Chair?
Yes.
Suggested motion is to direct Gallagher to continue the discussion with on PBM RFP results as per the conversation in executive session.
Okay.
So moved.
Second.
All in favor?
Aye.
Opposed? Carried. Discussion, consideration of, and possible action regarding dental and vision offering.
Madam Chair, I'd suggest tabling this item until the following meeting.
Okay. I need a motion to, is it table or continue?
Either continue.
Okay. We need a motion to continue this item to our next meeting?
So moved.
Second.
All in favor?
Aye.
Opposed? Motion carries. Discussion, consideration of, and possible action regarding MCEBT vendor renewals effective July 1st, 2023.
Madam Chair, this one and the next one, suggestion is to continue both.
Continue both, okay.
So moved.
Second.
All in favor?
Aye.
Opposed? And the next one is the consideration of and possible action regarding 2023-2024 MCEBT budget, benefit changes and rates. I need a motion to continue.
So move.
Second.
All in favor?
Aye.
Opposed? Motion carries. Now an administrative update.
Madam Chair, 2 items and a correction with an apology. We had this one put on the agenda incorrectly. The trust document is supposed to be an action item. We did not list it correctly, so what we'll do is, you have your copies, I would suggest you read it. This is the revised trust agreement, and just to discuss it, we've gone through, frankly, a considerable process to do this. This is the first update of the document since it was adopted back in 2020. What we've honestly done is simplified it and clarified quite a bit some of the roles and responsibilities. What it's really done, and I use this illustration with the Board of Supervisors, there was a provision in the former doc that rested the sole and exclusive authority for benefit decisions in this board. We believed, and staff agreed, and I believe council agreed as well, that this board is advisory. It is not the elected board. So for example, if this board, under that prior language, this board theoretically would have said, hey, we're going to implement retiree benefits for county employees, has no authority by election, and then the Board of Supervisors would theoretically have to do that as the taxing authority, essentially. So what we did is really clarified those responsibilities and simplified it quite a bit, and aligned it. There had been some amendments to Arizona Revised Statute 11981, so cleaned up. I think you'll find it an easier read. It's not something you're going to read like War and Peace, but it might have the same effect as far as your sleep. But I would suggest you read it. Next meeting, it's already been adopted by the Board of Supervisors. It'll be here for your approval or your adoption, and then for signature as trustees.
This is just cleaning up language. The process remains the same.
Correct. Well, I mean,
The Board of Supervisors always has the final say, as what we were talking about earlier.
Yep, they did. They do.
Okay, and the next requests for future action.
What about, oh, so I'm sorry,
that's
Madam
okay.
Chairman. There was 2 items on
The other one,
What
yeah,
is the
that's you're
one?
correct. And just basically saying, we're going to work with staff. Again, it's kind of effectively continued, but we'll be working with county HR staff to prepare for
We were
open enrollment.
continuing. Is there something we missed?
Yeah, it's second item on the admin update item. It's just a little line, just letting you know what we're doing.
Oh, okay. And so that's
That's it, no action, just
no
FYI.
action? Okay. And the request for future action, we went through that, nothing? Okay. And is there anything else anyone wants for the good of the order?
Madam Chairman?
Yes.
This thing that was handed out to us, this one is for the next session, right? We have not approved.
Part of the financials.
Yeah.
They didn't print correctly under the financial document past 17. It was the last two pages.
Oh, I think this was from
Yeah,
last
but I
year.
understand this is for fiscal year 23-24. So that's the budget for fiscal year
That's what we're talking about.
23-24 for the,
There'll be questions.
for the board. And we don't have the 23-24 budget.
As time as you need.
So.
We don't.
Yeah, but she's staff. She's a contractor, yeah. She's a staff.
It's for the next one, when we talk about that budget. Yeah. So, do you have another question about it?
No.
You're fine? Okay. Anything else? I'll take a motion to adjourn.
So moved.
Second.
We're adjourned.
So who's gonna do the schedule?